Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Ready for Prime Time, determining the current and future role of PARP inhibitor-based combinations in the management of prostate cancer. This is a think tank, and we have a great faculty today, Dr. Neeraj Agarwal from the Huntsman Cancer Institute at the University of Utah in Salt Lake City, Dr. Emmanuel S Antonarakis from the University of Minnesota at Minneapolis, Professor Karim Fizazi from the University of Paris-Saclay in Villefranche, France, and Dr. Susan Slovin from the Sidney Kimmel Center for Prostate and Urologic Cancers at Memorial Sloan Kettering in New York City. Here's where we're heading today. We're going to start out with sort of a few words about what's going on in prostate cancer in general, and then we'll be doing three different basic approaches to this topic. First, we're going to have the faculty do presentations and then discuss them. Then we're going to do a journal club where we pulled a couple of papers from each faculty person, and we'll talk about that. And finally, each of the faculty has some cases to talk about. We'll go through those briefly as well. So just to start out with you, Emmanuel, I want to, before we sort of dive into the whole PARP story and the combination story, maybe get your thoughts about kind of what's been going on in prostate cancer in general, particularly in earlier stage disease up to castrate-sensitive metastatic disease. From our perspective, as we talk to you and do CME programs in prostate cancer, there's so many things going on, but a couple of things that I think are going to kind of come up as we go through where PARP fits in. And I'm just kind of curious about your thoughts as we observe what's going on. The first is a movement, which also we've seen historically in breast cancer, towards intensification of endocrine therapy. So not just ADT alone anymore, but adding onto that, whether it's agents like abiraterone or androgen receptor signaling agents as well. And the other, which I can't think of any other situation in oncology where an imaging modality came in and had as much impact as PSMA scanning, Emmanuel, changing how we look at all the research that's been done without this. What do docs do? And then on this platform, we're going to talk about, where PARP inhibitors fit in. But any thoughts, Emmanuel, about these and other important trends and sort of the basic approach of what's going on nowadays?
Thanks, Neil, for that question and for the invitation. It's an exciting time, I would say, for our patients with prostate cancer. A lot is changing, and it's changing very fast. And it makes it challenging, but also fun for clinicians like all of us and all of you in the community to manage these patients. I think that I spent about the first 5 years of my career looking at PSA doubling time and PSA kinetics as a prognostic factor in early prostate cancer. And now I think that has become largely obsolete. And one of the reasons is what you mentioned is the advent of PSMA PET imaging, which has changed the way that we stage and prognosticate on our patients with biochemical recurrence. We now know that most patients with biochemical recurrence after prostatectomy or radiotherapy actually have microscopic metastatic disease that couldn't previously be detected with conventional CT scans or bone scans, but now can be detected with prostate-specific membrane antigen PET scans. There's been a second revolution in genetic and genomic testing, and germline testing and somatic testing is now routine in many scenarios, including in patients with early disease, the pre-metastatic as well. And I would say that most patients with high-risk localized or biochemical recurrence or even metastatic hormone-sensitive disease should undergo, at the very least, germline testing on every patient. And of course, somatic testing if a tumor biopsy is available, especially for the metastatic patients. So a lot is changing. It's very exciting. It's also getting a little bit more complicated, but I think this group here today will discuss some of those nuances.
Karim, any thoughts about this? And also what I was mentioning about intensification of endocrine treatment. It seems like that's going earlier and earlier into higher risk patients with localized disease. Any comments on that, and any other thoughts about how things are in sort of basic management of prostate cancer nowadays compared to 5 years ago even?
Yeah, I actually fully agree with what Emmanuel said. We saw, I think, three revolutions. The two you mentioned about imaging and biology, and how we integrate biology in our practice. And the third actually is what you just said, Neil, which is treatment intensification in earlier stages. When you think about abiraterone or enzalutamide, when they were first shown to be active in the very first phase 3 development program, basically, the benefit was about 3 months or 4 months in overall survival in terms of difference by medians. Nowadays, when we're using the very same agents early in the course of a disease, we're speaking about years of benefit. This is true in metastatic castration-sensitive disease. And now, more and more, I think we will use these agents even earlier. We just saw this year data from the EMBARK trial in biochemical failure. And a year before, we saw the STAMPEDE data with abiraterone, which, to me, are really impressive. If you look at the first decade of these men with very high-risk localized disease, so the worst scenario diagnosis besides the neurometastatic disease, these patients basically don't die anymore, at least for most of them, during the first decade. I think this is really fantastic.
So, Susan, another thought, I always think about people who are new to oncology. We've actually surveyed our audiences. We know that about a third almost have been in oncology less than 10 years. And for those of us who've been around more than that period of time, it's really stunning, the volume of research that we're seeing in oncology in general, particularly prostate cancer. I can remember how we agonized about the whole issue of PSO-only M0 disease, or using Hopkins database, et cetera. And all of a sudden, there's like a ton of phase 3 trials getting done, so industry academic partnership. So to me, it looks like a gigantic increase in clinical research that's had, really outstanding outcomes. Any thoughts, Susan?
Well, a lot of thoughts, and I've been around the field a little longer, I think, than I would like to give myself, the recognition for. But there's no question that we are having a very different perspective. It's interesting now with drug development that once upon a time we would look at one drug and that would be it. But then you have second and third and fourth generation drugs that come from this parent drug. And it has become very interesting to see how the nuances of each drug may or may not impact on the disease. And I think we've seen that perhaps with the PARP inhibitors, because there are nuances in how each of them will be essentially trapping the PARP molecules on the DNA and actually being able to be much more effective. I also think that we are now more interested in patient selection as a result of the interest and the research in biomarkers. There was a time when if you talked about a subgroup analysis that everybody would say that's the most odious thing you can do. We don't believe in subgroups. Now that's all we talk about, and it's been very advantageous, particularly if we're looking at all these intensification studies to find out going into the trial design itself, who is going to benefit, what group of patients will derive the most benefit. So yes, we've done a lot of changes, but there's a lot more that's going to be coming down the pike to really be advantageous for the patient.
So a final question to you, Neeraj. One of the things that we see very clearly and differentiates prostate cancer and GU cancers in general from many other solid tumors is the involvement of urologists. And we see the same thing with gynecologic oncologists. And those two groups are very much involved with clinical research. We just saw one of the most important trials, I think, in the history of prostate cancer, the EMBARK study, presented at the AUA meeting this year. And of course, the earlier stage of the disease, the more the urologists are involved. Any perception about how that's playing out, Neeraj? It seems like a lot of these big urology groups now have people within them who seem to specialize in, sort of what I would call the medical oncology or systemic therapy. Any thoughts about that issue?
Of course. First of all, I fully agree with what my esteemed colleagues here, Susan, Karim, Emmanuel just said. These are very exciting times. Medical oncologists are very tuned into the system of delivering toxic chemotherapies, toxic drugs, and they are very experienced with managing that, cytopenias, for example, or nausea and vomiting. our urology colleagues who are trained in a very different manner, many of them, fantastic surgeons, very busy clinicians and surgeons, but they may not have the experience of managing the adverse events of these drugs to the level medical oncologists have. And I think that's the first challenge I see as these drugs are increasingly managed by our urology colleagues. So how to deliver or how to get the education, not about the efficacy data. I think everybody is very familiar with the efficacy data, but how to get them in the system of how to manage those adverse events better, how to focus beyond efficacy and toxicity and quality of life. I think those are the issues I think are being faced by all of us as a community, but more by the urologist.
And as we go through this afternoon, I'll be sharing with you some of our experiences and observations when we talk about ovarian cancer, because of course PARP, that's where it really first started, where we started to see a lot of experience using these agents, as you were mentioning, in terms of tolerability, and now in breast cancer also. And also some of the things that are going on in these fields that I think are really relevant. I'm going to try to point them. I see a lot of analogies between some of the things that go on in breast and ovarian cancer and how they approach it and how it's being done here. And I'll bring some of that as we go through this today. All right, well, let's move into this first section where we're going to do presentations and then discussions. And really, a lot of times when we do these, we don't start out with the presentation. We start out with, other elements. But we felt it was really important to do it here because there's a lot of data to think through, and it's not that simple to figure it out. So we're going to take our time, work our way through it, and hopefully after we go through these 4 presentations, have really the data in front of us, and then talk more about how it's going to be implemented now and in the future. So we're going to start out with you, Emmanuel. If you could go through your presentation on the relevance of HRR mutations and castrate-resistant prostate cancer and treatment with PARP as monotherapy, which of course is where we started. Today we're going to focus on sort of the combinations, but this is great in terms of background. So Emmanuel, could please begin.
Thanks, Neil. And I know this is a symposium about combination therapies, but I'm going to set the scene and set up my colleagues for success when they give their talks after mine. So I'll talk about monotherapy, and I'll talk about some of the rationale behind why we are using PARP inhibitors in this disease. First of all, let's talk about the prevalence or incidence of homologous recombination repair mutations. And this is a list that I've created, Neil, over the years. This is my own personal list of relevant genes when it comes to PARP inhibitor sensitivity. The first tier on the left, which is characterized by BRCA1, BRCA2, and a few other genes, are the ones where if they are mutated, the sensitivity to PARP inhibitors is the greatest. There's a second tier with genes like CDK12 where sensitivity to PARP inhibitors could be intermediate. And then there's a third tier where we now understand that these genes probably do not predict PARP inhibitor sensitivity even when mutated. So how common are these? These are 2 of the landmark papers. There are many, many others. At the somatic level, if you sequence a metastatic biopsy from a CRPC patient, you'll find a homologous recombination mutation in about 25 to 30%. So you can think of that as 1/4, maybe up to 1/3 of patients. But the surprising thing was, if you look at the germline DNA, the inherited DNA of these patients, 12% of men with metastatic prostate cancer have an inherited mutation in one of these genes. So that's about 1 in 8 men. And the most common, of course, is BRCA2, followed by the others. The NCCN guidelines now recommends germline testing in virtually all prostate cancer patients, irrespective of whether they have localized disease or metastatic disease. And somatic testing, shown on the right-hand side, is recommended primarily for metastatic disease because that's where the PARP inhibitors and other targeted therapies, including pembrolizumab for mismatch repair deficient disease, is indicated. Now, this was a review article that I wrote a few years ago about my approach to identifying HRR mutations, and other people may have slightly different algorithms. For me, a fresh metastatic biopsy is always the first choice if it's feasible and safe, followed by a circulating tumor DNA test if a biopsy is not feasible, for example, if you have bone-only disease. Third best choice for me is an archival biopsy, such as a primary prostatectomy or prostate tumor biopsy. And then if none of those three are available, a germline-only test could be used as a last resort, but only as a last resort because you will be missing all of the tumor-derived mutations if you only analyze the germline. Let's now focus on the data for the monotherapy of PARP inhibitors. And I'm going to begin with one slide about synthetic lethality. So as we know from other cancers like ovarian, breast, pancreatic cancers, these drugs work by crippling both single-strand and double-strand DNA repair. The PARP1 is the main component of single-strand repair, and that's what's inhibited by the drug. And double-strand repair is crippled by the mutations themselves. So when you have a patient or a tumor with a mutation in BRCA1 or BRCA2, that cancer is unable to fix double-strand DNA breaks. So it compensates by fixing DNA breaks one strand at a time using PARP1. And in that context, if you inhibit PARP1 pharmacologically, you can induce catastrophic DNA damage and hence cancer cell death. We now have 4 PARP inhibitors that have been tested in prostate cancer. 2 of these 4 have been approved as monotherapies, olaparib and rucaparib. And then talazoparib has also been approved in combination with enzalutamide, and olaparib has been approved in combination with abiraterone. They each have slightly different potencies in terms of their PARP1 enzymatic inhibition, and some of them also PARP trap on the DNA, as was mentioned by Susan Slovin, and the most potent PARP trapper is in fact talazoparib, and that may enhance its clinical activity. I don't want to dwell on this table, Neil, but if the audience wants to look into this on their own time, they can do so, but I'm going to highlight the key studies one by one. And let's begin with the data for olaparib. Again, I'm only going to cover the monotherapy indications here. And the monotherapy trial of olaparib was called the PROfound study. This was a randomized phase 3 trial in patients that had one of 14 homologous recombination gene mutations, either BRCA1, BRCA2, or ATM, or 11 other homologous recombination genes, cohorts A and B. Patients with metastatic CRPC who had received one or more novel hormone therapies and up to one chemotherapy were randomized to receive olaparib, 300 milligrams twice a day, or physician's choice, which here included either enza or abi. The study was positive for its primary endpoint of rPFS and also had a strong signal towards the secondary endpoint of OS, showing an improvement in both progression-free survival and a trend in overall survival using olaparib monotherapy, 300 milligrams BID, relative to either abi or enza in the control arm. And this is the combined analysis of all 14 genes, in other words, cohorts A plus B as a composite analysis. However, when people like me like to look into the details, you can see here that the benefit of olaparib is most pronounced in mutations of BRCA1 and BRCA2, and perhaps a rare gene called RAD54L, but is less pronounced or non-existent for many of the other genes. And in fact, when you look at a gene called PPP2R2A, try saying that fast, you can see that in fact there was a improvement in the control group. In other words, a detriment of olaparib in patients that have that gene. And that gene came off of the FDA label. It fell out of the label and it's not included. So PPP2R2A is not on the package insert for olaparib. But 14 genes are listed on the package insert, and they are shown on the small print at the bottom, including our favorites, BRCA1 and BRCA2, plus 12 other genes. And this led to the FDA approval of olaparib as a monotherapy 3 years ago, believe it or not, May of 2020, in men that have received one or more novel hormone therapy and up to one chemotherapy. The chemotherapy was not required, so a patient that has never received docetaxel would still be eligible for olaparib as long as they have received one or more of the novel hormone agents and they have a mutation in one of those 14 genes. The next drug is rucaparib, and the developmental program of this agent was the Triton-2 and Triton-3 studies. Triton-2 was a single-arm study without a control group in the third-line mCRPC population, followed by Triton-3, which was a randomized study one line earlier in the pre-taxane population. Let's talk about each separately. So the Triton-2 study was the single-arm design, no control group, that took about 100 patients with one of these gene mutations and then treated them with rucaparib by itself, looking for objective responses. This is the initial analysis presented in 2020. It's been subsequently updated in 2023 with a few more colors added to this graph. The colors denote the different gene mutations. So the dark blue are patients with BRCA1 and BRCA2. The waterfall plot shows objective lesions in soft tissue responses, in other words, objective response rate. You can see that there's many blue bars here with pretty impressive responses. Those are the BRCA2 and BRCA1 patients. But you can also see, if you cast your eye to those red bars in the middle, those are 4 patients with PALB2 mutations. All 4 of those, 4 out of 4, had an objective response. And then you can see the occasional orange or green patients with other gene mutations. But the dominant sensitivity population here are the BRCA1, BRCA2 patients. And this drug, Neil, was approved only for patients with BRCA1 and BRCA2 alterations, not the other genes. And that was a decision that the sponsor made when they filed for approval. And here the indication is a third-line population, and the patients must have progressed not only on an AR targeting therapy, but also on a taxane chemotherapy as well. The phase 3 study was called Triton-3. This was an mCRPC population pre-chemotherapy, and the randomization was rucaparib versus control group. And the control group now had 3 choices, either ABI or ENZA or a taxane. So this was the first study, Neil, where a taxane was incorporated into the control arm to mimic the real-world patient population. And this study, as presented by our esteemed colleague Karim, was positive for the overall population here. As you can see with the rucaparib shown in blue and the physician's choice shown in red, this is rPFS. But interestingly enough, and the authors disclosed this on their publication, the patients on the left-hand side are the ones with BRCA1 and BRCA2 mutations. The patients on the right-hand Kaplan-Meier curve are the patients with ATM mutations. You don't need a statistician or a p-value to see that the benefit was exclusively seen in the BRCA1-2 subpopulation, not the ATM population. The FDA has yet to expand their label, so the label remains at the moment only for BRCA1 and BRCA2 patients. And we shall see if this trial leads to the expansion of the label or not. I have my doubts. The third agent is niraparib, and this was the Galahad study. This was a medium-sized study of about 50 patients or so. Again, this was non-randomized, single-arm, and all patients got the niraparib, which is a monotherapy PARP inhibitor, 300 milligrams daily. And as you can see here, there was activity primarily in the BRCA1-2 mutated patients, shown in blue on the waterfall plot, and less pronounced activity in the orange, which are the other non-BRCA HRR mutations. Of note, niraparib does not have any FDA approval at the moment, neither as a monotherapy nor as a combination therapy. And finally, talazoparib. This was the phase 2 study, 100 patients, called TelePro-1. Again, looking at objective response rates and PSA response rates. The waterfall plot here shows the objective response rates. The blue patients, light blue and dark blue, are the patients with BRCA mutations, and then the other ones are the additional genes. Again, you can see that PALB2 in red shows a pretty decent benefit. We don't have an FDA approval for talazoparib as a monotherapy. We do have one in combination that will be discussed later. The side effects of these drugs as a class, and they're all overlapping, include anemia and thrombocytopenia to a lesser degree, fatigue, as well as nausea. Some of them cause a rash. Primarily, rucaparib is the one that it's involved with a rash. And also some of them cause AST, ALT elevations. In conclusion, I hope I've convinced you that germline and somatic testing is very important in metastatic prostate cancer. Olaparib is approved as a monotherapy for HRR mutated patients with one of 14 gene mutations. Rucaparib is also approved as a monotherapy only for BRCA1 and BRCA2 patients. Niraparib and talazoparib have also been explored as monotherapies, but neither one has a monotherapy indication. These drugs work best against BRCA1 and BRCA2 mutations, and we are in need of additional biomarkers to help us select patients beyond the genes that have been mentioned before. Thanks very much.
Thanks, Emmanuel. Just a few follow-up questions. First, to start with Karim. I'm curious if you can kind of provide kind of a broad viewpoint of single-agent PARP in the advanced metastatic setting in prostate cancer, in terms of the benefits that you see. How often do you see patients who have, good responses that last for a couple of years? Is that rare? Is it common? From your own, kind of going beyond the trials, how do you, when you're getting ready to use PARP monotherapy, what are you thinking you might be seeing, Karim?
Sure, thanks, Neil. So we will, I guess, discuss later on about the debate about using a PARP inhibitor in combination with an AR pathway inhibitor in all comers versus in men with mostly BRCA alterations. To be honest, I think because of this all-comer discussion, we're probably missing how much the benefit of PARP inhibitors has been important for men with BRCA alterations who are actually men with quite terrible cancers. BRCA alterations is associated with poor prognosis. And as Emmanuel just alluded in his talk, we see a quite enormous efficacy of PARP inhibitors in these men with BRCA alterations. And I think we should really remember this because it's really great news. And yes, in my experience, I've been using these 4 agents as a single agent, and they do work. And sometimes they do work for a long time, especially for men with BRCA2 deletions, not mutations. And I think this is important to remember. And I would like to reemphasize what Emmanuel said, which is test your patients and make sure your test is a good one, if possible, based on tissue, because actually the blood test may miss some BRCA deletions. So in other words, you may miss the opportunity for the best patients to benefit. Having said that, I still don't understand why not all patients benefit when they have BRCA alteration. And it really remains a mystery because, we can discuss about the exact response rate, probably 50%, 60%, whatever, but still some patients clearly don't derive any benefit. And we don't really understand. So it means that auto test remains imperfect. There's still room for improvement.
So, Susan, any thoughts on that provocative question about why patients with BRCA don't respond? And also, I'm curious, in ovarian, they have this LOH score, which is not it's a score. It's not a particular mutation. What are your thoughts about that type of assay predicting benefits from PARP inhibitors in prostate cancer?
Prostate cancer remains a very challenging cancer. Ovarian has always been very responsive very early on in their development with the PARP inhibitors, and the loss of heterozygosity of the tumor it's a very unique type of tumor, which has, I would say, gradations of genomic alterations that really show responses to these agents, unlike prostate cancer per se. I think my major concern about these agents in general is how one in the community can really be using these drugs, especially when it comes to trying to do the actual assays to look for these markers. Emmanuel brought up some very good points in his little algorithm of, how do you find these, using fresh tissue, prostatectomy specimens, CTCs, etc. But what do you do about the community? And I hope it's okay if I just direct this to Emmanuel. What do we do, because a lot of our community colleagues are not able to even get these tests done? I think a lot of the issues we've faced in looking at these phase 3 studies evaluating all the PARP inhibitors is that not all trials are created equal, even when it comes to looking at the tissue samples, because some of them have been done prospective or even retrospective. So Emmanuel, your thoughts about what do we do with our community colleagues when they really want this type of panel, but they don't have the same ease as what we would do at some of the larger cancer centers or institutions?
And not to mention economic issues preventing, reimbursement issues preventing a certain amount of workup. The docs may want to do it, but they may not get approval to do it. Emmanuel?
Yeah, so reimbursement and resourcing issues aside, I think germline testing can be done in every patient. There's never going to be a patient where you cannot obtain a saliva sample or a blood sample. So that should be done on everyone. And then the tumor testing, one thing to remember, and I do want to emphasize this, is archival prostate biopsies or prostatectomy specimens, if there is a BRCA2 mutation, they're going to pick it up in most cases. In other words, these are not mutations that are typically acquired over time during the clonal selection of the metastatic tumors. They're usually present at the beginning. Now, having said that, if a radical prostatectomy or a prostate biopsy is more than about 5 to 10 years old, the DNA may not be adequate enough to do the analysis. And in those patients, especially with patients that have a bone-dominant metastatic pattern, we can use a liquid biopsy such as Guardant 360 or Foundation Medicine liquid assay. And as long as patients have a PSA burden of about 10 nanograms per ml or higher, those patients are likely to have circulating tumor DNA.
I wanted to ask Neeraj, because I want to move on and allow Susan to do her presentation. But Neeraj, one thing I was sort of flashing when Susan was talking about archival specimens. I was working with you on a program a couple of months ago, and you mentioned something I never thought about or heard about, which is clinics and hospitals throwing out their specimens after 10 years, how much of a problem that is. And the other thing I wanted you to comment on, Neeraj, is something I feel like we talk a lot about in breast and ovary, and not quite in the same way in prostate, which is platinum agents. Right now in ovary, they like to use PARP as maintenance after platinum. In breasts, a lot of times they consider platinum resistance similar to PARP resistance. So any thoughts about clinics throwing out their specimens and also platinums in prostate cancer, Neeraj?
Great question, Neil. So first of all, I would like to talk about our experience when we were doing the PROfound trial. And this was the first time ever a biomarker-based trial was being conducted in the setting of prostate cancer. And it was amazing to see how many patients had their surgeries done locally outside of big academic centers. And when we tried to obtain the slides or tissue blocks, we were just told that we don't have them or they have been thrown away. And then I realized that most of the local laboratories do not keep the samples for more than 10 years, and many after 5 years. So that has to change, in my view. The second challenge we faced was, even we got the blocks, the quality of the DNA, as Emmanuel mentioned in the talk, the quality or the quantity of the DNA in those blocks was not sufficiently good enough to allow testing. And that taught me two things. Number one, I need to test my patients as soon as I see them and not wait for them to develop castration-resistant disease, because by the time, which happens after 3, 4, 5 years, the original tissue blocks may be gone. And number two, as we already discussed, to try to obtain ctDNA samples or germline testing if there is no option of tissue blocks being available. Now, switching to your second question about using platinum-based agents for patients with homologous recombination repair mutations in our prostate cancer patients, I use PARP inhibitors because these are backed by prospective trials. Many of them are randomized trials, as Emmanuel presented. If I don't have any option of obtaining PARP inhibitors, either because of, which is mostly driven by lack of reimbursement or lack of ability of my patients to afford the copay for those agents, then I go with carboplatin in my clinic, mostly for BRCA2 and BRCA1 patients, BRCA1 and BRCA2 positive patients.
So we won't talk about whether you can get carboplatin or not, which of course is a pretty big issue nowadays. Let's move on now and start getting into the combination data that's come out over the last couple of years. It's been so interesting and challenging to try to interpret. Susan, you put together a talk on current and emerging precision medicine therapies for prostate cancer. Could you please begin?
Well, thank you, Neil. I would say that we are really in a very unique time in terms of precision medicine. And just to remind people about precision medicine, there's a lot of different aspects to it, of course, as you can see here in terms of prevention, diagnosis, and treatment. We have, as part of our precision treatments now, something identifiable, which are the PARP inhibitors, as already been alluded to. We do have PSMA, as you've alluded to, and now we're going onward for the combinations. Emmanuel touched upon this very briefly. This is just to remind everyone that we're seeing as many as 44% of men with BRCA2. This is something that was really unheralded before. We never expected BRCA2 to be apparent, and of course, knowing this has led to the NCCN guidelines about the importance of doing genomic profiling literally in every patient, as you can see here, with prostate cancer who presents either with high-risk disease as characterized by PSA of greater than 20, Gleason 8, 9, 10, etc., metastatic, nodal disease, or just features, as you can see here, that are high risk or very high risk. And this is particularly important, I think, in terms of guidance for our urologists and radiation oncologists, as well as our medical oncologists. Emmanuel has already very nicely reviewed about the approved PARP inhibitors of olaparib and rucaparib, and you can see the differences in the more, liberal encompassing of olaparib for a variety of HRR mutated genes. So to touch upon really our dose intensification, if you will, or intensification work that's been ongoing and certainly led by Karim with some of his work in combinations with chemotherapy, we have 3 trials that have been under a lot of discussion, sometimes heated discussions at ASCO. One is the PROpel trial, which is abiraterone, prednisone plus olaparib, the magnitude trial of abiraterone, prednisone, and niraparib, and of course talapril, which is enzalutamide, and talazoparib, keeping in mind that talazoparib is probably the most potent of all of the PARP inhibitors. So the rationale for PROpel was really based on some preclinical work, phase 2 data that showed that there was a combination or a synergism with anti-tumor effects when you used olaparib along with a next generation androgen receptor signaling inhibitor, which was abiraterone. This was a double-blind phase 3 trial, and it was given to patients in the first-line castration-resistant setting. Patients were randomized 1-to-1, as many of you recall, with standard doses. And the enrollment was irrespective of the status, whether it was homologous recombination repair mutation status or BRCA. And of course, they used retrospectively tumor tissue and circulating DNA as opposed to prospective. This is just a very brief review, just showing you the randomization as seen there. And you can see there was data cutoffs at very pre-specified intervals. At the end of the day, there was radiographic progression-free survival by investigator assessment versus blinded independent review, and you can immediately see that there was, in fact, benefit in the combination in terms of radiographic progression-free survival, which was the primary endpoint, and by blinded independent review, so very, very good concordance. And at a median follow-up of about 19.4 months, the combination of olaparib and abiraterone showed significantly improved median progression-free survival, which was about 8 months, which had a p-value of less than 0.01. And this was again confirmed by looking at the blinded independent review. So interestingly, the magnitude of this positive effect was seen in patients who had the homologous recombination mutations versus those who did not. The hazard ratio was 0.5. And in a subgroup analysis, the benefits for radiographic progression-free survival were also observed, irrespective of having had prior chemotherapy, for example. There was a suggestion of, based on pre-specified analyses of a survival benefit, which was more or less a trend in the intention to treat group. The data was only 48% mature at the time that this was suggested, but it might be anywhere from 42 versus 34.7 month difference, which may in fact be quite clinically significant. And this is just to give you an idea here, based on Dr. Clark's work, of the events and the differences in terms of the overall survival. Again, not confirmed, but apparently suggestive of about a 7.4 month survival benefit. You can see the hazard ratio there, but again, we're not quite at the level of significance. Now, what about just looking at imaging only? And this was a paper by Clark in New England Journal of Medicine based on this study, and overall survival was a secondary endpoint. And they actually found here, too, a confirmation of what they saw in some of the earlier work, that there was definitely a benefit, although overall survival was immature. And the standard side effects appear to be somewhat worse in the combination arm, with the usual asthenia and fatigue more in the combination with PARP than without the PARP. This is just to give you an idea of the patient characteristics, well balanced between both groups. And this is the Kaplan-Meier estimates of imaging-based progression-free survival, as you can see here, in favor of the combination arm. Again, investigator evaluated versus blinded independent review. Forest plot of these pre-specified subgroup analyses of imaging that was for the progression-free survival. And again, investigator initiated. You can see from the size of some of the circles of the events in each of these groups. And it did favor a greater patient population with the BRCA mutation. And again, demographics, just to give you an idea of the treatment emergent adverse events. Again, consistent with those side effects that are already known for PARP inhibitors. If you look at the biomarker analysis that was presented by Fred Sad in this patient population, it was very interesting because there was a very large discussion about the importance of BRCA-ness, if you will, in patients who had been on this study. Their data obviously confirmed that there was a prolongation of radiographic progression-free survival in patients who had metastatic castration-resistant disease following docetaxel, irrespective of the genomic status. And on first analysis of patients on the group, those who did not have any biomarker positivity seemed to also have benefit, which was something that was rather unexpected. So the takeaways for this study was that the combo showed a significant improvement in radiographic progression-free survival. There was an improvement of greater than 8 months, suggestion of radiographic progression-free, the intent to treat, but there was also an inclination toward overall survival. But one of the concerns that kept popping up, do details matter in the molecular stratification? What kind of BRCA-ness are we looking at? And I say that only because the thought is that abiraterone perhaps upregulates BRCA-ness and maybe makes the patient population much more susceptible to the effects of the PARP inhibitor. Nevertheless, can you use CTCs to really look at the BRCA-ness? And as Emmanuel has already pointed out, is there a relevance to the kind of tissue that we're looking at in this particular case? Now, magnitude, again, same kind of concept, phase 3, randomized, double-blinded, but here think the benefit of this trial showed that the importance of getting tissue prospectively as opposed to retrospectively, which often is a major criticism of these trials. So here we have randomized, double-blind, multi-center, Abi and prednisone, along with niraparib, 2 groups, with or without. Biomarkers were pre-screened in the cohorts. They all had homologous recombinant repair mutational changes. This was determined using tissue and blood samples, so very, very well annotated, as you can see here. The details I think you can see when you have a chance to look at these slides. But here you have those patients who had the biomarker positive. They were randomized to get niraparib plus abiraterone prednisone versus placebo plus abiraterone, and those who were biomarker negative. And the primary endpoint here too was radiographic progression-free survival. So a futility analysis was inherently put into the trial to make sure, in case there was a lower likelihood of clinical benefit, that the combination arm did not have the homologous repair deficiencies, may not be effective, and therefore it would be determined sooner, and that would be ending that particular portion of the trial. So the futility analysis was planned when approximately 200 patients had been enrolled and about 125 composite endpoints, either PSA progression, radiographic progression, or death had occurred. And the primary radiographic progression-free endpoint was powered for and tested first in the BRCA1/2 group. And if they had determined statistical significance, the remainder of these homologous repair positive patients would be analyzed. And approximately 50% of these patients were specified to be BRCA1 or BRCA2 positive. So based on the futility analysis, there was no benefit in the patient arm that was HRR negative. There were grade 3 adverse events with the addition of niraparib. Again, not unexpected given some of the side effects of the PARP inhibitor. However, if you were to look at radiographic progression-free survival, again, in these 2 populations, clearly a benefit in those patients who had the HRR mutations versus those who did not, both by independent review and investigator review. So the conclusions that were drawn from these groups is that the combination treatment with niraparib and abiraterone prednisone definitely lengthened radiographic progression-free survival, but did not seem to have any benefit in those patients who were HRR negative. So where do we really stand with this group? Well, magnitude was designed to determine which group of patients would derive the greatest benefit, which is really what I think all of these trials are doing. There was prospective profiling, but again, the patient population was a little bit different than PROpel in that these patients were allowed to have prior chemotherapy. They were allowed to have prior PARP inhibitors, and that may have added to some aspect of it. So I would say that what these studies really tell us is that there is a need to do genomic profiling. As far as we're concerned, from diagnosis until death, anytime there is a change in the continuum of treatment where you're failing one treatment going on to the other, it's extremely important, I think, to do genomic profiling. We do know that these metastases vary in clone, and there's really I think a concern that maybe not all PARP inhibitors are the same, and of course considering brachygness. So with that, I will stop and say thank you, Neil, for the opportunity to present this.
So Karim, I'm curious how you were thinking about these data up until we saw the Talipro data earlier this year. But when we had these 2 trials presented the year previously, what your thoughts were, and particularly the issue of why was there benefit seen in the HR proficient patients with PROpel, but not with magnitude. At that point, what were you thinking, Karim?
Right, and this was probably the key question a year ago. As you rightly said, and beautifully shown by Susan, the 2 trials shown with pretty much the same data, let's say, for men with BRCA alterations. Clear benefit whatever the PARP inhibitor was used, patients with BRCA alterations benefited. Fine. But it really was a surprise for the first time to see the PROpel data apparently showing benefit for men without BRCA alteration and actually without any HRD alterations. While magnitude did not support that, which was kind of expected based on previous phase 2 experience with PARP inhibitors. So I was, and I guess we were wondering whether PROpel was not simply a false positive, which happened in science, of course. And as Susan alluded to, one of the weaknesses PROpel had was that the HRD status was actually set after randomization, as opposed to what was done in magnitude, where the status was known prospectively, which of course is a strength of magnitude. So we were really wondering whether it was simply an issue related to the test. The fact that TelePro-2 tend to confirm PROpel indicates that it is unlikely that PROpel is a false positive, or then you would have to hypothesize that 2 trials are falsely positive, which is unlikely. So I think something is happening with the combination of AR targeting and PARP inhibition in men without BRCA alteration. The question is why? Is it just because the gain-order test isn't perfect and we're missing some BRCA alterations, especially the deletions, which are not that easy to pick up using a blood test? Is it because when we're targeting at the right same time PARP and the androgen receptor, we are generating a BRCA-ness environment? It could be. Some preclinical data suggests that it is, but we're not sure. Or is it because what we call PARP inhibitors do something else besides PARP inhibition, which is possible? We all know that we call aspirin a painkiller, but it's doing some other things, and that's true for many drugs. So we have to tease this out, and I think it will take the time. So this is the science, the scientific question. The medical question is really whether the benefit in these patients without BRCA alteration is sufficient for use. And I think we should probably have this debate after we have shown or seen the TelePro-2 data.
And again, you think about cancer research in 2023, incredible, 3 phase 3 trials in a year, and pumped out. And for us to take a look at, we're going to look at TelePro-2 in a second. But Emmanuel, any thoughts about if there is benefit from PARP inhibitors in the so-called HR proficient, what's going on with the mechanism might be? And also in terms of these trials, like where are these patients today? Like, are there, people are getting novel hormonal therapy earlier and earlier, or do we have patients right now who fit into these categories?
Neil, I think that the mechanism of the synergy or potential synergy in the HRR negative patients is going to be a bunch of hand waving and circumspection. There are, if you look at the preclinical literature, you can certainly find 2 or 3 papers that support the hypothesis that inhibiting the AR causes a DNA repair deficiency, but you can also find a similar number of papers that shows the opposite. Karim mentioned a very provocative potential explanation, which is that the PARP inhibition might be doing something to the AR. PARP inhibition might be directly or indirectly inhibiting AR function or localization in the cell, or it's binding to DNA potentially. There are some preclinical provocative data even suggesting that. But the medical question for this audience is, does the benefit risk equation in those patients who are HRR negative, known HRR negative, is the benefit worth the risk? And this is the issue that the FDA and ODAC tried to tackle when they eventually decided that no, olaparib and abiraterone should only be approved in combination for the BRCA1, BRCA2 patients. And so when you have a benefit that might be lukewarm, let's call it that, but the toxicities are the same, right? So the toxicity profile doesn't change, but the benefit becomes less, then the ratio of risk divided by benefit becomes larger for the risk and lower for the benefit. And I think that is the clinical conundrum that we have to face in our clinics.
And any thoughts about where these patients are, since so many people are getting early novel therapies?
I think the proportion of patients who reach first-line mCRPC never having received abiraterone or enzalutamide is becoming smaller and smaller, and that does present a problem because both of these trials primarily, although not exclusively, primarily enrolled patients who had not seen any other novel AR-targeted therapies. Now, they did allow it, and there was a small proportion, between 1% and 4%, that had received a prior novel hormone therapy in the HSPC setting. But I think it was not a huge number. So we just have to extrapolate and use our best judgment. So for example, if I had a patient who had received ADT enzalutamide or ADT apalutamide as their upfront metastatic castration-sensitive therapy, and now they are first-line mCRPC, should I use abiraterone plus olaparib in that patient? And I struggle with that because we know that abiraterone does not have much efficacy after enzalutamide or apalutamide fail. Could that lack of efficacy be overcome by combining it with a PARP inhibitor? It's possible. I would still hesitate. And that's the elephant in the room, is that these patients that reach first-line mCRPC having never received a novel hormone agent are fewer and fewer.
So hopefully we'll see some PARP data in the endocrine sensitive situation that'll solve the problem. Be interesting too to see how the FDA responds to TelePro-2. And even if they, I don't know, maybe they'll take another look at PROpel. I don't know. Now they've got another trial with some more data. And that really does bring us to these two incredible presentations that occurred this year, first at the GU meeting and then at ASCO. And we asked Neeraj to review his data.
So thank you for the opportunity to discuss the PARP inhibitor combination treatments for advanced prostate cancer. And we have already discussed today the PROpel and the Magnitude trial. So I'll focus on TelePro-2 trial, which we had the opportunity to present in this 2023 GU ASCO meeting, and then ASCO 2023 meeting, followed by the publication of the paper recently. So I'll summarize all those data in the next 8 to 10 minutes. So let's look at the genomic landscape of advanced prostate cancer. Emmanuel has done a wonderful job of talking about how common these mutations are. And then we heard from Susan about the prevalence in germline setting. So I will not delve much time into this, except that there are a lot of patients out there, 20 to 25% patients with metastatic prostate cancer who harbor these homologous recombination repair mutations or DNA repair mutations. Now, coming to the rationale for combining PARP inhibitor and a novel hormonal therapy, as Karim said earlier during our discussion today, PARP inhibition can suppress AR activity, and AR activity, when it is suppressed, it leads to upregulation of poly-ADP ribose polymerase. And if both are suppressed together or inhibited together, it may create a state which may resemble BRCA-NES without actually the presence of a HRR mutation. So this is the rationale, preclinical rationale out there. And this was basically validated by a prospective trial we called Study 8, presented and published in 2018, actually, in Lancet Oncology by Dr. Noel Clarkson group. And then that trial led to multiple large phase 3 trials, as we have been discussing today. But let me take a step back and highlight the question, Neil, which you asked. How many patients have really progression, have had progression on a novel hormonal therapy before they reach the state of metastatic castration-resistant prostate cancer. I hope we are able to publish those data by end of this year, but our prelim observation from the multiple patient level data sets, which are massive data sets used by these many of the external entities such as Flatiron, such as IQVIA, and so on, our estimate is 40% patients have been exposed, not progressed, to novel hormonal therapy by the time they reach first-line MCRPC. But let's look at, until we have the data, let's look at how patients progress to MCRPC. The large number, the vast majority of patients present as localized prostate cancer. And these patients are mostly cured by surgery or radiation, but we know that 30 to 35% patients progress to biochemical recurrence after failure of radiation and surgery, or both. And they are mostly treated by intermittent ADT and then followed by continuous ADT. And a time comes when PSA is rising despite intermittent or continuous ADT, and you get a PSMA scan, PSMA PET scan, or CT scan, we find invariably, as Emmanuel said, metastatic prostate cancer. And this patient population is predominantly seen by our urology colleagues, and some of them are by radiation oncology colleagues. As medical oncologists, we don't see these patients. Then let's go on to, so this is going to be a large patient population, which is leading to MCRPC without any exposure to novel hormonal therapy. Second scenario is the metastatic castration-sensitive prostate cancer, where we have shown in multiple studies that less than 50% patients, more like 40% patients, have received novel hormonal therapy until actually 2022, last quarter of 2022. And all these patients, and this was not confined to United States, this was present, the same situation was present in pretty much all developed countries, in European countries, in UK, in many other countries. And if this is the state here, we can imagine what is the state in emerging economies, where the patients don't have resources or doctors don't have time to convince the patient to start intensified therapy when their PSA has dropped by 90% with ADT alone. And then we are talking about this new scenario, locally advanced prostate cancer, where we use novel hormonal therapy for a short duration, 2 years. And then these patients develop metastatic castration-resistant prostate cancer, what you do with those patients. And there are new trials coming up, ENZA-RED trial, DHSL high-cap trial with darolutamide, enzalutamide, which are going to be using short duration novel hormonal therapy. What you do with these patients? Do we determine that that NHT is no longer an option in these patients who receive limited duration novel hormonal therapy? So this debate will continue until we show the data by end of this year. So let's move on to the high attrition rate of our patients from first line to second line. These are two large studies from Flatiron database, earlier published by Dr. Dan George and team, second by Umang Swami and team, who is here, our colleague in Huntsman. We showed that there is a 40% attrition rate of patients from first line to second line to third line. We pretty much lose 40 to 50% patients to disease progression. And that's why that is one of the reasons intensification therapy works in prostate cancer and pretty much any other cancer. So in my view, whenever we can intensify, we should try our best to intensify, both in hormone sensitive setting and earlier castration-resistant prostate cancer setting. Now I'll go to the TALA-Pro2 data, which we presented early on and just published in the Lancet. And these are essentially two trials. And this is how we like to present the trial. First 803 patients were all comers. And among all comers, 169 patients had homologous recombination repair mutations. And then we added additional 230 patients with homologous recombination repair mutations. So we presented that on first 803 patients first, and then Karim presented the data on the homologous recombination repair positive patients in the ASCO 2023 meeting. So I'll first show the data on the unselected patients first, which included both negative and positive patients. And some of them, we could not even determine the status of HRR positivity, despite the fact that 100% patients got prospective tissue testing done in this study. And we can see here that the presence of BRCA1, BRCA2, CDK12, CHEK2, and all other mutations were pretty much representative of what you would expect from a population. And this was the primary endpoint. Radiographic progression-free survival in all comers was significantly improved with the combination of talazoparib plus enzalutamide, with a 37% reduction in risk of progression or death. If you look at subgroup analysis, there is no doubt looking at this efficacy forest plots that every subgroup seemed to be benefiting, with the caveat that these individual subgroups are not powered for independent analysis. But I was curious to see that patients who got abiraterone or docetaxel, they seem to be benefiting, maybe of higher degree than the patients who did not get abiraterone docetaxel. This is just an intriguing hypothesis generating subgroup analysis, but it was very interesting for me to see that patients are benefiting regardless of de novo disease, non-de novo disease, high Gleason score, low Gleason score, age, and so on. And if you look at the presence of this benefit, depending upon whether patients are HRR deficient, there was a 55% reduction in risk of progression or death with the combination. And if you look at patients who are non-deficient, by prospective tumor tissue testing, we decided to specifically look at this analysis. There was a 34% reduction in risk of progression or death, even in those patients who were HRR non-deficient by prospective tumor tissue testing. And we are just talking about the data right now, not the decision making in the clinic. Overall survival is immature. We don't have enough events yet, so I will not talk about that. But if you look at the other clinically relevant endpoints, such as time to PSA progression, time to cytotoxic chemotherapy, objective responses, all seem to be benefiting. If you look at the side effects, none of these discussions are complete without discussing the side effects. We did see a lot of side effects, but if you carefully look at the side effect profile, it was driven by anemia. 46% patients, to be precise, had grade 3 or 4 anemia. But if you look at how many patients had grade 1 or 2 anemia at baseline, 49% patients. And this tells us how aggressive the disease is in this patient population, which is HRR positive. When you have half of the patients presenting with grade 1 or 2 anemia, even when they are eligible for a clinical trial. But bottom line is, how many patients had to discontinue talazoparib due to anemia? 8.3%. So message here is, the median time to onset of anemia is 3.3 months. Follow these patients closely. Patients who develop grade 3-4 anemia, they will likely require dose reduction, but more than 50% patients will not require dose reduction. And hence, early follow-up, reducing the dose in patients who really need it, I think will be sufficient. And as oncologists, we have done this for docetaxel chemotherapy and for many other chemotherapy in prostate cancer. The best part I liked was the time to deterioration and quality of life, as reported by the patient, was significantly delayed with the combination compared to enzalutamide. And this further consolidate my positive feelings about the combination in this patient population. Now let's go to the homologous recombination repair mutation positive patient results, which was presented by Karim in the ASCO 2023 meeting, and hopefully we'll publish the full manuscript very soon. And again, I will like to focus on those 399 patients here who are HRR positive. And I will not delve too much time into the detail of demographics and disease characteristics. Again, they were very representative of the population. Again, we did not see any predominance of one subset of gene driving the benefit. The gene subsets were pretty well represented, as you would expect from a patient population. The best part was radiographic progression-free survival. There was a 55% reduction in these patient population. If you look at who benefited, again, subset analysis, all subsets seem to be benefiting in this patient population. If you look at the subset analysis, again, these are small subsets Some of the subsets had single-digit numbers in each of the arms. So obviously, trial was not powered to look at individual gene subset, but I was intrigued to see that even patients with CDK12 mutation or had a 50% reduction in risk of progression or death. And of course, we know about all the subset. I don't want to talk about individual subset and what was the RPFS because trial was not powered or designed to do that. If you look at overall survival, strong trend, I would say, and I'm really hoping that we will show positive overall survival benefit, hopefully in the near future, looking at these trends. There was a 17-month delay in PSA progression in patients in the combination arm. On the baseline of 11 months, the combination induced a time to PSA progression of 28 months. This is very meaningful to my patients when I discuss with them. Of course, we are going to look at several other endpoints, such as time to cytotoxic chemotherapy, response rates, again, very favorable to the combination. If you look at myelodysplastic syndrome or acute myeloid leukemia, we have not seen any cases of that, even in HRR positive patients, although there were 2 patients in the all-comer patient population. If you look at anemia, 55% patients had grade 1 or 2 anemia at baseline, and this tells me how aggressive the disease population is. But again, most of them were manageable with dose reduction in a timely fashion. Quality of life favored the combination. And to conclude, per FDA approval, I'm offering this combination to my patients with HRR positive metastatic castrate-resistant prostate cancer in my clinic nowadays, based on these strong data. And I really hope we will show overall survival benefit and further toxicity results in the upcoming publications. With that, thank you so much.
So thank you very much. I have a pretty simple question I'd kind of like to ask all of you. I'm going to start with Susan, which is, let's put aside the FDA and access. If you could access whatever you want, what would you like to do? What would you prefer to do with a patient who has, let's say, a BRCA mutation? Would you use, for patients in this situation, a combination of novel hormonal therapy or abiraterone with a PARP inhibitor? Which PARP inhibitor? And then same situation, except patients HR proficient, 100%. So what would you like to do, Susan?
What I'd like to do is really be able to secure for the patients, number one, the drug, which I can tell you is likely to be, this combination may be very challenging money-wise. The second is, ideally, this treatment, in spite of BRCA or HRR, is not necessarily going to be appropriate for every patient coming in, particularly if we're having older patients. And remember that when people are on androgen deprivation therapy, they are going to have a normochromic normocytic anemia, but the greater the level of disease infiltration into the marrow, the greater the likelihood of anemia, which could be very easily exacerbated by this combination. Ideally, in the most perfect world that does not exist, I probably would favor this combination. I think there's a lot of strength to it. I will tell you just anecdotally, which will impact on the case a little later that we'll discuss, that I've actually had a patient who was BRCA2 and used olaparib along with abiraterone, and it did not touch the patient in any way, shape, or form, only to find out with a quick punchline that it really wasn't BRCA that was driving this cancer. So even though I think this is very important observation, I'm more inclined, because I think the toxicity profile is a little bit easier with this combination than it would be for olaparib and abiraterone. My only real concern is sometimes are we really over-treating patients with this? Can it wait a little bit down the line? And number two, what endpoint do you use to be convinced? I mean, this is all very convincing data. Are you a person who likes to look at radiographic progression-free survival as the modus operandi for driving your treatment, or should we all be waiting for overall survival benefit to really drive it? And I don't know that there's a right answer there. I think that the data are very compelling as it stands right now, but a lot of people, and including patients, really want to see survival data before they even embark on this kind of intervention.
So let me try to pin you all down a little bit more. Karim, let's imagine you're in a situation where you can use either talazoparib or olaparib, or, I guess you could say niraparib in a patient with a BRCA mutation combined with hormonal therapy. First of all, any preference in terms of the PARP inhibitor, Karim?
Right. Actually, in Europe, interestingly enough, the EMA made a different decision as compared to what the FDA made. And we can actually, officially at least, use olaparib in combination with abiraterone, regardless of the molecular alterations. Having said that, in other countries, approval doesn't mean that you can really use, because reimbursement at the end of the day is the most important thing. So, I'd be happy to propose a PARP inhibitor plus an AR drug, basically in any of my patients with BRCA1 or BRCA2 alterations, if they have not received an AR drug for hormonal sensitive disease. I think we don't have enough data to support that, as Emmanuel said already, I think, in patients who have seen these drugs in castration-sensitive space. I will maybe give it a try also in a man with PALB2 alteration, perhaps also in a man with CDK12 alterations based on what we saw in TRAPRO2. And probably not in other patients. And maybe one exception would be a scenario where I see a young man with a terrible history of cancer, breast cancer, ovarian cancer, prostate cancer, maybe pancreatic, and out of a sudden he is negative based on a blood test. I would maybe consider one of those combinations in such a scenario, thinking that the test just missed a BRCA2 deletion. Now, if I have to choose between the PARP inhibitors, I would really have a hard time. I used them all; they all work. We don't, as we all know, there's no direct comparison. What we saw in TRAPRO2, I think Susan said that already, was a higher degree of anemia, if we can compare, which actually we should probably not. And it's true that having to transfuse, say, almost 40% of patients is not nothing. But also the degree of efficacy we saw in TRAPRO2 was perhaps higher, again, in a situation where we should not compare. So, but Neil, at the end of the day, it's more about availability and reimbursement, as we all know. So it's really hard to provide a guidance about choice between PARP inhibitors based on scientific grounds, I think.
Well, that's very helpful, though, I think, for our people to know, and in terms of how you view that. Emmanuel, I'm curious, same question to you. In a patient with a BRCA2 mutation, any preference about PARP inhibitors? Would you use this strategy? And if you could, would you use this strategy in an HR proficient tumor? And if so, which agent?
So I'm going to answer the question a bit more directly, Neil, and making the assumption that the patient has not received abiraterone or enzalutamide in the past, and they are BRCA2 mutated and they are now at first-line mCRPC, I would favor olaparib plus abiraterone. There's two main reasons for that. For me personally, one is I have 3 years of experience with olaparib. I use it a lot as a monotherapy, and I'm comfortable with the side effect management. The second reason is the overall survival of the combination of olaparib plus abiraterone in the BRCA1/2 patients has a hazard ratio of 0.29 with an upper limit of the confidence interval of 0.56. I didn't say PFS, I did say OS. And an overall survival advantage with a hazard ratio of 0.29 is absolutely striking. We have never had any clinical trial in the history of prostate cancer oncology with an overall survival hazard ratio of 0.29, 71% reduction in death. And I'm not saying that the TelePro study may not show the same thing. I just simply have not seen that data. It's not available to us. And unless that data becomes available for me, with that published estimate of 0.29 OS in the combination, I think that's a very strong rationale, again, in a patient who has not received abiraterone in the past, to combine abiraterone plus olaparib. If I have a patient who has received ADT plus abiraterone, and they're now progressing to first-line mCRPC, I may well choose to use enzalutamide plus talazoparib in that setting, even though the trial did not really include a large number of those patients, but I would consider it.
So again, HR proficient, Emmanuel, would you want to use a PARP inhibitor, and if so, which one?
It would be the rare exception. In that setting, I wouldn't have a preference as to one versus the other, and I would do it in a young man with an aggressive cancer and perhaps other signs of homologous recombination deficiency. For example, I had a patient in my clinic with a very high HRD score or LOH score, but without any detectable BRCA1 or BRCA2 mutations. So the assumption in that patient is he has a mutation somewhere it was missed. Perhaps it's a deletion that was missed, like Karim mentioned. Perhaps it's a genomic rearrangement that inactivates the gene that was missed. These complex structural rearrangements are hard to find. But if the HRD score is high and he's otherwise fit, healthy, young, has aggressive disease, he would classify as HRR non-deficient or non-mutated, and I would potentially consider that if I had the regulatory approval to do so.
It is interesting that I hear, I'm going to ask Neeraj in a second to finish it out, but so far I'm hearing a lot of hesitancy about using this strategy in HR proficient patients, and I'd like to hear a little bit more about why not. I mean, you got a lot of patients, pretty decent hazard rate. I mean, it's not as good as what you see with HR deficient and BRCA, but I don't know, kind of interesting. So Neeraj, what's your thought? Again, putting aside access, it was pure oncology science. Any thoughts?
Yeah. So first of all, I'd just like to make a comment on exposure versus progression on a prior NHT. So if somebody receives 2 years of abiraterone in the STAMPEDE setting where patients had locally advanced prostate cancer, I will definitely use another novel hormonal therapy in the first-line mCRPC setting. And in my view, Neil, I'm just wanted to make a comment on the choice of abiraterone, olaparib versus enza-talazoparib that may be driven by the base drug, what patient can avail. So if patient's insurance only approve abiraterone, then there is no choice but to go with olaparib. Or if patient cannot have enzalutamide just because they are on a blood thinner, which doesn't allow them to go on an enzalutamide base strategy, then there's no point discussing talazoparib with the patient. So I think the choice may be driven in my clinic by more logistical reasons rather than what we like to do. But coming back to your question, HRR negative patient, I didn't want to ignore that question. The easy answer right now is we don't have approval. And you said just leave aside approval for a second and just say what you will do. I want to look at more long-term data on safety and overall survival trends. So I hope that after 1 year, I'll be able to answer your question in a more convincing fashion. Right now, I will not use it in HRR negative patients.
So that's a really great, we could talk a lot about this, but let's move on to the final presentation. Karim is going to talk about future directions in terms of use of PARP inhibitors. Please begin, Dr. Fizazi.
Thank you very much, Neil. So I will try to cover only two topics regarding the future. We never know what the future is going to look like, but I think we can probably discuss combinations and future combinations, and also earlier use of PARP inhibitor. And of course, I'm happy to discuss informally some other issues, resistance, we already did. So let's start with combinations. And this slide here summarizes the main ongoing or planned trials. You'll see in orange the phase 3 trials, and in gray phase 1 and phase 2. So obviously this is predominantly dominated by combination with androgen receptor therapies, as we just heard. We have basically 4 trials, and one is actually missing, at least amongst the one we saw in terms of results. And this is the Casper phase 3 trial with recombination. We've just discussed the 3 others. And you'll see that there is only one other phase 3 trial with PARP inhibition combinations, which is with immunotherapy. I'll come back to this in a second. Now, regarding phase 1 and phase 2, there are combinations with, for example, radioligands, radium-223, lutetium PSMAs, and chemotherapy, and some other drugs. But again, for the sake of time, I will not discuss everything. So let's discuss for a second immunotherapy. Obviously, there was a rationale for combining PARP inhibitors with immunotherapy, at least for patients with BRCA alterations. Not completely sure about patients without BRCA alterations. And indeed, PARP inhibitions will perhaps generate more cancer antigens and more release in interferon, which will perhaps make the combination work. We tested this hypothesis in a phase 2 trial with recombination. And as you can see, we see a pink phenomenon. Pink is because this trial was enriched in patients with HRD alterations, and pink is for BRCA2 and BRCA1 alterations. And you can see just on a glimpse that it appears that BRCA2 and BRCA1 patients derive most of the benefit from this combination. Hard to know whether they derive more benefit as compared to what would have happened with recombination single agent, because we didn't really have a control arm in that trial. We actually have now data from a phase 3 experience combining pembrolizumab and olaparib, and this was shown some months ago at ESMO. As you can see here, by the design of the trial, men head-to-head failed one AR drug, abiraterone or enzalutamide, and one taxane, obviously mostly just Taxol. They were randomized on a 2-to-1 patient between pembro and olaparib, or the second AR drug, abiraterone or enzalutamide, depending on what they had received first. So again, we're not really testing whether the addition of immunotherapy really helps patients receiving a PARP inhibitor. We are actually testing a combination, namely pembro and olaparib, versus, to be honest, a weak comparator, which is the second generation AR pathway inhibitor. The trial is negative. Completely negative by its primary endpoint of overall survival. You can see to the right of the slide that patients with BRCA alterations do derive overall survival benefit. But again, based on because of the design of a trial, it's impossible to figure out whether this overall survival benefit seen in BRCA patients is related to recombination only, or to the combination of recombination and pembrolizumab, which remains an unaddressed question. As I said before, there are other combination. And this is, for example, COMRADE, which is a phase 1/2 trial of radium plus olaparib. There is a randomized part after dose expansion. And right now, I think we have data from 2-dose testing. And actually, what we see is, some efficacy. For example, to the right-hand side, you see ALK-Phos responses, which is quite high. But again, same criticism as before, very hard to figure out whether this is simply related to the efficacy of radium-223, which quite often is associated with ALK-Phos responses, or actually the efficacy of the PARP inhibitor in men with BRCA alterations. You see at least one patient actually had BRCA alterations. And the same applies to PSA response in a non-selected population of men. Well, just a month ago at ASCO, we saw the very first findings from the LuPARP phase 1 trial combining lutetium PSMA and olaparib. This was presented by Dr. Sandhu. And I'll make it brief. This is a PSA response seen in LuPARP. Clearly, there is efficacy from this combination, but again, same criticism, very hard to figure out whether this is mostly related to PSMA lutetium. Again, this is an all-comer population, not necessarily an HRD population, or whether adding the PARP inhibitor actually increases the efficacy, especially in non-BRCA patients. And those are the details. Of course, the PSA 50 response appears to be high, and some patients tend to benefit by RECIST, but the number of patients is really low, 7 out of 9 patients. So it's really hard to compare, even if we use the benchmark of therapy or vision, which are randomized phase 2 and phase 3 trials respectively, but I think it's really hard to compare. So this is their conclusions. I think the beauty of the trial is that they were able to test different combination, different doses, and they were able to show, or at least to suggest, that combining olaparib for about 3 weeks in a 6-weekly cycle can be done safely with lutetium PSMA, but we really need comparative data to tease out whether this combination is better than just a single use. Now, the second big thing I think we're waiting for in the future is earlier use of PARP inhibitors. And the next step is probably metastatic castration-sensitive disease. As you can see here on the slide, there are 2 phase 3 trials, Amplitude and TALAPRO-3, testing this hypothesis, but also some other smaller trials. So let me, for the sake of time, let me go straight to the design of these 2 phase 3 trials. This is TALAPRO-3. It's enrolling patients, as I said, with metastatic castration-sensitive disease. These men can have received systemic treatment with a doublet, ADT, and an AR pathway inhibitor, the one you like, actually, abiraterone, enzalutamide, olaparib, or darolutamide. And after the HRD status has been determined, patients can be enrolled if they have NHRD mutations, mostly BRCA, BRCA1, BRCA2, but also some others, and you see the list. And they are randomized to receive enzalutamide alone or with a placebo, actually, or enzalutamide and talazoparib, as we did pretty much in TALAPRO-2. So the primary endpoint is radiographic progression-free survival, and a key secondary endpoint is overall survival. And the trial has actually completed its accrual, so it's already an accrual success. Let's see what the data show in the future. The second phase 3 trial is called Amplitude. It's very, very similar in design. The difference is mainly about the PARP inhibitor and the backbone AR drug, abiraterone, and this is being tested alone or in combination with niraparib. Approximately almost 800 men are planned in that trial. Again, the primary endpoint is rPFS. So waiting for that, but we also have some preliminary data in even earlier stages, thanks to Emmanuel and his group. This is olaparib in patients with biochemical failures after localized disease, after prostatectomy. It's a non-comparative trial. Patients are receiving olaparib if they have HRD alterations. And you can see here again the preliminary data with, again, this pink phenomenon. And pink, again, is about BRCA. And you see that patients with BRCA alterations clearly derive benefit from olaparib in this setting, while patients with other alterations typically do not derive benefit. Of course, I'm happy to ask Emmanuel to comment more about all this if he likes. So I think what's interesting here is that at least for some of these men with BRCA alterations, the durability of the efficacy is there, and you can see that some of these patients actually have a PSA down to 0 for quite a long time, and some of these men, as I understood it, are still on drugs. So that is potentially interesting for these men, including maybe some men who don't want to receive castration. And this is it, and I hope I'm not too long. Thank you very much, Neil.
No, that was really great and really exciting. So far, it's been really great. I've learned so much today. It's really this is an awesome experience for me. So we're going to move on now and go through the Journal Club, which is really going to be an informal discussion, and we're not asking you to do in-depth Journal Club presentation, but more just sort of more global about the topic and whatever came out in the paper that was relevant. I want to start out with this paper, Karim, that you were on looking at the tolerability and adverse event management in the PROfound study, and also just to lead into a general discussion about your experience with tolerability of PARP inhibitors, of combinations, particularly with novel hormonal therapies, and the kind of toxicity issues that you see. What did you see in the PROfound study? And in general, what's been your experience when you use a combination of novel hormonal therapy and a PARP inhibitor, Karim?
We know from a long time, mostly thanks to the ovarian experience, that the two main side effects or immediate side effects are typically GI tract related, mostly nausea, and hematotoxicity, mostly anemia with a related fatigue. So in my experience, the nausea is not a major issue. And the drugs we're usually using to circumvent nausea, to prevent it, typically work, in my experience. The anemia, the fatigue, and the decreased appetite, which are related, is much more of an issue. So people need to be aware of that and need to be prepared to give patients some holidays, some drug holiday, and also use dose reduction as appropriate, and of course monitor. So that is very important. Having said that, people need also to be conscious that there are some rare but existing toxicities which are very important for decision making. And I'm speaking about leukemias and myelodysplasias. They've been reported again and again with PARP inhibitors, which is really cause, in my opinion, for a very sounded decision making when we prescribe PARP inhibitors. We have to have a good reason to prescribe these drugs. Also, at least with some of them, there can be pneumonitis And it also appears that patients receiving PARP inhibitors have a higher likelihood to develop thromboembolism, including pulmonary embolism. For example, in PROpel, this was reported, I think, in 7% or so versus just 2% in the control arm. So again, even if this is rare, it's not nothing. So we need to, to be called, to be serious doctors, and just don't prescribe a PARP inhibitor because someone told us to do so. This is very serious decision.
In terms of tolerability, Susan, another issue is the partner to the PARP inhibitor, abiraterone versus enzalutamide. I feel like as we've been doing our programs, I'm hearing more and more about not using abiraterone, a move away from abiraterone. How important is that part of the equation in terms of combining with a PARP inhibitor? And any evidence that the endocrine therapy changes the toxicity profile in any way, Susan?
I mean, it's an excellent question. We wrestle with this all the time. Abiraterone, either drug or neither drug, I should say, is really a lightweight drug. We pop them out to patients like candy, but there are patients who are older, other medical comorbidities for which the fatigue or the transaminitis that we see from abiraterone has actually circumvented its use. I'm actually very surprised that in the combination, there's really been no reports of dose-limiting toxicity as a result of the transaminitis. I have patients who are very healthy and on single-agent abiraterone after 2 or 3 months, all of a sudden I'm seeing AST and ALTs in the 100, 150 range, just out of left field. And even withholding drug, getting back down to normal levels, and then having the drug, for example, we're still seeing that there are some people who cannot tolerate that. And you really have to be super vigilant. My problem with the PARP inhibitors is, as was just discussed, is always the concern that you already have a drug, which is abiraterone, that may have undue toxicity going down the line. It may not be immediate. And the addition of something, a drug such as a PARP inhibitor or any of them, can worsen a lot of the side effects that might be there. Now, a lot of the data we're seeing shows tolerability, but I don't think that all patients are created equal. And I think the tolerability is going to be very, very variable depending on the patient. Of course, we can always dose reduce, but there are concerns about the anemia and the nausea. And that's really a lot of what I've heard that has been prohibitive to treating some of my patients, even if they do need the drug. They just can't tolerate the fatigue and the anemia of the PARP inhibitor, independent of the abiraterone. So I think we have to be very circumspect for each patient to get a sense of what's going on and how to manage them better. It's hard.
Yeah, we did a case-based program at ASCO, and one of the cases was a patient who had severe hepatic toxicity with abiraterone. Neeraj, any thoughts about this? It sounds like from what I heard you all saying that you kind of want to stick with the partner that was in the trial. So if you're going to use talazoparib, it's going to be with enzalutamide. Is that correct? And if you're going to use olaparib, it's going to be with abiraterone. And any thoughts, Neeraj, about how that affects the way you perceive the choice, and particularly in terms of tolerability?
I'll make it very simple, Neil. The answer is short. Answer is yes. I will only use this PARP inhibitors with the combination partner as they were tested in the clinical trials.
So I'm curious, Emmanuel, what's your, not so much about PARP inhibitors, but am I correct in perceiving a movement away from abiraterone, or is that happening in your practice as well, Emmanuel?
No, I don't think that's correct, Neil. I think that these drugs have unpredictable toxicities. And, I've been doing prostate cancer oncology for a long time, and I keep getting it wrong myself. So I have a patient who I think is going to tolerate abiraterone beautifully, and his LFTs go up to 500. And I have the patient who I think is not going to tolerate enzalutamide because he's 85 and he takes it and doesn't have any side effects at all. And I've seen everything in between. In general, I would say that I use the two drugs relatively interchangeably, about 50% for each one. If someone has very poorly controlled insulin-dependent diabetes, that is a patient that I would shy away from the abiraterone plus prednisone. If I have a patient with uncontrolled seizures, I may shy away from enzalutamide. If I have a patient with pre-existing liver dysfunction or is taking a statin, I may avoid abiraterone. But I use both routinely.
Great points by Emmanuel. My practice is very similar. Almost half of the patients get abiraterone, half get enzalutamide. My experience is if patients can afford both, is very much driven by affordability also. So if they can afford both and they are eligible for both, they tend to go with a drug which doesn't require frequent monitoring for electrolytes, and they usually don't want concurrent steroids as we have to do with abiraterone. So enzalutamide is more frequently chosen by the patients if they have access to both.
So Neeraj, we pulled a couple of papers. You actually referred to the patient-reported outcomes paper from ASCO. I always love the patient. Sometimes the patient-reported outcomes really is informative, and it's really great even just to look at it. And then this other paper, one of the reasons I was curious about was this diagram. I never understand all these diagrams, but I'm just kind of curious, not so much at a molecular level, although feel free to explain it molecularly. But Susan, to what extent do you think there's a difference in terms of efficacy, mechanism of action? You hear about the trapping, that, quote, talazoparib is more effective. Are these sort of scientific variations or things that you think actually have clinical meaning? It's hard when you have two different phase 3 trials you're trying to compare indirectly. But when you look at it biologically, more and more I hear stories in all parts of oncology where you start out thinking that all drugs are the same, and then you start to realize maybe they're not. BTK inhibitors and CLL, everybody thought were the same. Now they have a new one, zanubrutinib, and it actually seems better. They have sort of mechanistic responses. Same thing with the CDK inhibitors in breast cancer. Initially, they thought they're all the same. Susan, from your point of view, can you sort of dissect out any difference in these agents?
Well, it's an interesting question, and one that comes up quite a bit, because I think we faced the same issues when we were looking at enzalutamide, apalutamide, darolutamide. There's never going to be a 1-to-1-to-1 in one trial to compare them all. On the other hand, they all have a very different way in terms of avidity, for example, at least in those drugs. However, for the PARP inhibitors, there is a difference, I think, from a stereochemistry standpoint. And for example, talazoparib has a much more rigid structure compared with niraparib or olaparib, for example, and there's a difference in how much, as we had alluded to earlier, how much PARP it traps on the DNA. So do I think there are differences? Yes. Are we able to really dissect the differences at that level? Because at this point, the answer is no. I think it's hard for me to really have an appreciation of whether or not it truly affects efficacy in the long run, because we really never, ever, as far as I think is going to happen, going to compare one with the other. We went through that with paclitaxel versus docetaxel. Everybody said one was better than the other. There were differences in how it, in terms of its impact on the aspects of the cell attack. But at the end of the day, I don't think anybody's going to look at that. But inherently, and from a scientific standpoint, I do think that there are differences. But whether or not they really would translate to differences in response, et cetera, I think remains to be determined and may ultimately never be determined.
Emmanuel?
Yeah, I'll just make one data-driven comment, and that is in patients with CDK12 mutations, the data seems to suggest that talazoparib is the best one. This is my own personal opinion. Other people may not agree with it. The trial that Karim presented at ASCO 2023, the HRR positive subset of the TelePro-2, there was a very compelling, I think, RPFS benefit with talazoparib plus enzalutamide versus enzalutamide alone in the CDK12 patients. That has not been seen with other PARP inhibitor agents. So this might be, in my opinion, one specific circumstance where there could be a discriminating factor.
So, Neeraj, we also pulled a couple papers, and you clearly have done a lot of work in the issue of liquid biopsies. And without going into, these are just some papers for the audience to check out, but maybe you could just summarize some of the things that you've learned. And I think one of the key things that people, of course, people want to know is, to, first of all, to what extent, is prostate cancer a cancer that sheds DNA, that you can look at circulating DNA compared to other solid tumors? And of course, so what do we know in terms of false negative when you compare it to tissue, Neeraj?
So prostate cancer patients create a unique challenge to us in terms of obtaining tissue, especially when they have bone predominant metastatic disease. Many patients simply don't want to have biopsies. In castration-resistant prostate cancer setting, they have had local tissue removed years ago many times. And as we discussed earlier during this meeting, that many of these patients have no tissue available, which is sufficient from quality or quantity wise to allow testing for homologous recombination repair defects. So in this backdrop, the value of ctDNA testing is even more relevant and more prominent in my perspective compared to many other disease types. So if you look at the publications which came from PROfound trial, the first phase 3 biomarker-based trial in prostate cancer leading to approval of olaparib, in a post hoc analysis, if you look at the concordance, so when tissue was positive and ctDNA was tested, and when tissue was negative and ctDNA was tested, in both settings, there were very high level of concordance, 80 to 90% agreement between the positivity of the tissue and ctDNA and negativity of the tissue and the ctDNA negativity. So that's a message coming from the first abstract, which was presented, or first publication by Dr. Kim Chi, detection of BRCA1, BRCA2, and ATM alterations in matched tumor tissue and ctDNA testing. Now, if you look at the second publication here, published by Dr. Matsubara, where we looked at the efficacy of olaparib in patients with metastatic CRPC who had BRCA1, BRCA2, and ATM alterations solely identified by ctDNA testing. So there were 181 patients out of 200 plus patients who were originally in the main cohort 1 of the PROfound trial, which only focused on these 3 mutations. If you look at the efficacy of olaparib over the alternate NHT, which were abiraterone or enzalutamide, the efficacy of olaparib was consistently present and was of the same degree as we saw in patients who were tested by tumor tissue testing only. So the efficacy of olaparib was similar, regardless of whether these mutations were detected by the ctDNA or tumor tissue. So that these data actually added to my level of confidence in the ctDNA testing when these data were earlier presented in the poster form or abstract form, like almost 1.5 years ago. Now we have a lot more data from the perspective of ctDNA testing. And we consistently see whether you see these mutations by tumor tissue or ctDNA, we have similar results. And these data make it so much more compelling to do ctDNA testing in our prostate cancer patients who do not have tumor tissue available for any reason. The last abstract was the presence of BRCA1 and BRCA2 and the concurrent landscape. I thought this is just an intriguing hypothesis generating study by our group. We looked at 7,000 patients who were tested by ctDNA testing, and there were 600 plus patients who had BRCA1 and BRCA2. And we looked at concurrent genomic profiling of BRCA1 and BRCA2. And it was intriguing to see that BRCA1 was associated with other mutations such as EGFR or AKT mutations versus BRCA2, which was mostly a sole player. And that informed me that probably in case of BRCA1 mutated prostate cancer, there are other drivers which are present versus BRCA2, and that is basically validated by much better efficacy of PARP inhibitors in BRCA2 only patients versus BRCA1.
Karim, can you elaborate a little bit more on that last point in terms of your thoughts in terms of differences of response to this or any other differences you see in BRCA1 versus BRCA2? Also, any differences between somatic and germline from the point of view of efficacy as well? Any thoughts, Karim?
Sure. You know, Neil, the big issue we've been facing is that BRCA2 alterations are actually much more frequent, much more prevalent as compared to BRCA1 alterations. So any trial, even phase 3, typically has 5, 10 patients with BRCA1 alterations max, as compared to whatever 50 or 60 patients with BRCA2 alterations. So this is really a big challenge. And the first trial, for example, Profound, suggested that patients with BRCA1 alterations may not benefit from olaparib treatment. But again, I can't remember the exact number, but this was really a very small number of men. So, and actually, personally, I had, even at this time, I already had experience with patients with BRCA1 alterations who clearly benefited. So I was really happy to see in TALAPRO-2, which actually had a quite high number of patients with BRCA alterations, including those with BRCA1 alterations. I was happy to see that the hazard ratio for rPFS is very similar, or almost the same for patients with BRCA1 and BRCA2 alterations. So in other words, if we trust this data, and of course I'm using all caveats because the numbers remain small, it appears that patients with BRCA1 alterations do derive benefit from PARP inhibition, here talazoparib. Now, your other question was, yes, about somatic versus germline. When this all started, my hypothesis was honestly that patients with germline alterations may benefit more, simply because all their cells have to have the alterations given its germline. For example, BRCA2 alterations. While for somatic alterations, it can be a subset of cancer cells, but not all. So I was really thinking that these patients with germline alterations may derive a greater benefit. It actually appears that it's not the case. Most of the studies that have focused on this question really reported very similar efficacy across the board, which is great news for patients. It means that if you detect somatic alterations, the patient has probably a similar likelihood to benefit.
So I want to ask Emmanuel about several papers. It's always a challenge. And it's one thing to put a paper in the literature with the results of a study, but it's another thing to try to get into commenting on it and particularly getting into clinical applications. So I admire that you took all these shots to try to contribute to these questions that there's so much controversy about. I love the title of the middle one there, PARP inhibitors for prostate cancer tangled up in Profound and PROpel and TALAPRO-2 blues. Can you talk about, and of course these evolved over time as the first two papers were presented and then the TALAPRO paper was presented. But just to reflect back, and we talked a little bit about, obviously we've talked a lot about these trials, but I'm just curious some of the things that you and your co-authors went through in trying to kind of bring this issue out into the literature, Emmanuel.
Thanks, Neil. These are all either editorials or review articles. The first one, which was the JCO article that I wrote with Dr. Wasim Abida, was commenting basically on the niraparib magnitude study. And the key thing about that editorial was that Dr. Carducci, who is the GU editor of JCO, gave me permission to create a very spicy figure 1 for the editorial. And the reason that it was spicy was we decided to directly compare the hazard ratios of magnitude versus PROpel, even though the studies obviously everyone would say should not be compared. But since we are key opinion leaders, we thought we have the right to do so, and we did. And it did appear that when you compare the hazard ratios for the overall unselected population as well as the HRR positive population, that perhaps, again, another provocative comment, that olaparib plus abiraterone might be more efficacious than niraparib plus abiraterone. There's few potential reasons for that. One, niraparib might be an inferior PARP inhibitor, potentially. Two, the dose of niraparib had to be reduced by 33% compared to the monotherapy dose, whereas the full dose of olaparib could be used in combination with abiraterone. The second paper that was entitled "The Blues," the credit for that goes to Dr. Johan de Bona, who has been on your show before, Neil, and Johan came up with that title. But that was an editorial that he and his team led that I was peripherally involved in, but I was not the driver of that one. And it was basically bringing up all the controversies. And by the way, it was published about a week before the ODAC meeting. So it fueled, I would say, some of the controversy that ensued during the ODAC meeting, where the main thrust of that paper was whether we have enough evidence to approve this for all comers or whether we don't. And his slant was that we don't yet have enough evidence to approve in all comers. And then the third one is a review article that it's now 9 months outdated, summarizing what Karim summarized even better than I could ever have done, which is the combinations of PARP inhibitors with other agents. So just some review articles for reference, or if the audience is interested in looking at them.
Yeah, it's interesting, in ovary with niraparib, they have the weights and plates thing where that they adjust the dose down in these women. Also, you mentioned Dr. De Bono. I always think about the fact that he joked with me that he calls PALB2 BRCA3, which I thought is kind of fun. Susan, I'm curious about your take on, again, bringing out into the literature some of the questions that are coming out as a result of these combination studies. Anything else you want to add to the discussion we've already had, Susan, in terms of trying to make decisions moving forward? And any thoughts about the FDA decision? We see this throughout oncology. A lot of the PD-1 trials where they, the overall trial is positive, PD-1 low is not. And the question is, who's going to make the decision, the FDA or docs in practice with their patients? Any thoughts about the FDA decision, Susan? Any other thoughts about these data?
The one thing the FDA has as its major charge is keeping drugs and the American population, essentially all Americans, safe. I mean, that's really what it's about. I think the issue is that we often are faced with the data that looks very tantalizing, and we're getting trials where the product is fast-tracked, and that's where we end up having issues sort of in the retrospectoscope. Are we approving drugs too quickly only to pull them back? So even with the FDA's approval, sometimes we find undue toxicities in the post-hoc analysis, the phase 4s, where we realize that perhaps the drug is not targeting the best population and maybe has undue particular side effects. I would say in general, I agree with what my colleagues have said. I mean, we are trying very, very hard to make a major difference. My major concern, however, is that sometimes taking the data is being somewhat even though it's a phase 3, we do have physicians, for example, both in academics and in the community, who will start using the drugs in unspecified clinical scenarios. And I've been seeing that more and more, patients who are coming in from the community, where they're being started on any number of non-FDA approved PARP inhibitors, either alone or in combination with any of the androgen receptor signaling inhibitors, with the hope that they're able to get the same kind of efficacy. I did want to ask one question, Neil, if I may, and that is, this is a question that's come up before, but if a patient fails one PARP inhibitor, would anybody consider doing another PARP inhibitor? Because I've seen, again, people coming in from other institutions where that has been tried.
So, Emmanuel, any thoughts about that? Again, in ovary, there's some data suggesting maybe there's a difference? Any thoughts?
I would not do that, Susan. I would consider a platinum agent such as carboplatin, but I've never used two PARP inhibitors back to back.
So I want to finish out the journal club and move on to the cases in a second, but I pulled also a couple papers from Susan, and while it's slightly outside of PARP inhibitors, I just had to ask about it because I was really curious. The first thing is we're hearing about ADCs all the time in many solid tumors, breast cancer, lung cancer, bladder cancer, as you all know. And I didn't know that actually sacituzumab is being looked at in prostate cancer, so I'm curious whether this TROP2 ADC has any potential future. And then, of course, I got to ask you about CAR T and what you've seen there. So any comments, Susan?
Okie dokie. So I can tell you that Dr. Lang has been working feverishly to look at mechanisms of resistance to androgen receptor signaling inhibitors. And the paper is, I believe, just come out recently. And the idea here, I mean, this sacituzumab Globinatican has been approved for triple-negative breast cancer and bladder cancer. It's not a lightweight drug, but it is an antibody-drug conjugate with a humanized antibody against TROP2, which is a pan-carcinoma antigen, which happens to be very heavily expressed on prostate cancer cells, that is conjugated to SN38, which, as many of you know, is a active metabolite of the topo-1 inhibitor irinotecan. Go figure that this would have some efficacy, but what's been very interesting is that this is actually turned into a biomarker study, but for patients who again, this was a non-biomarker in the sense that all comers came in for this trial. You didn't have to be TROP2 positive, but we did retrospectively go back. And as it turns out, 95% of the patients did have TROP2, but using sacituzumab initially was thought to perhaps have impact on the PSA 50, which is one of the endpoints, and also the radiographic progression-free survival. We really did not see any significant impact on PSA, although there seemed to be a 64%, although only 40 patients, seem to have impact on with an improvement in radiographic progression-free survival. So the paper just came out. There's more data there, and Dr. Lang and his group has been working very hard to look for associations between the expression of TROP in patients who have been treated, the timing of the androgen receptor signaling inhibitors in terms of efficacy. So it's an ongoing story. In terms of CAR T cells, this was a very unique immunologic platform in that this was a non-viral transduced CAR T cell. This is an autologous CAR T cell platform that uses a transposon, or a little piece of DNA that's put into a scaffolding called centurin, and you're able to put in any gene that you want, but the end result is the generation of a memory T cell that essentially just keeps revving up. It's actually based on preclinical data. This platform has shown efficacy in 2 prostate cancer models with complete eradication of the disease. It's a very bone-tropic platform, which means this kind of CAR T cell seems to be very specific for bone. So we, in this 40-patient trial, which was multi-center, phase 1, were able to show 2 complete responses, along with PSA that had really gone from, in one particular case, 33 to less than 0.1, happened to be my patient. And we were able to do FDG and PSMA PET scans prior to the treatment, 4 to 6 weeks after treatment, and at 3 months. We were shocked to find that both bone scan, FDG, and PSMA PET scans 4 to 6 weeks after had markedly diminished SUVs, and by 3 months the SUVs were almost down to less than 2. It was very concerning because when you look at the bone scan, it looked improved. The PSMA and the FDG PET scans really showed marked diminution by greater than 75% in the SUVs. And when you put a needle into that area, all we saw was bone remodeling. And we went back and asked pathology to please go back and look for immune cells, and they identified CD4, CD8 cells, and by PCR and after sending the specimen to the sponsor, were able to demonstrate the presence of CAR T cells. So this is, to our knowledge, really the first report that we've been able to see a complete eradication of disease. Patient's PSA was 33, went down to decimal point 1 with literally a complete radiographic and biochemical response that lasted for over a year, and similar to with another treatment, another case that we had. But more importantly, we were also able to redose the patient with CAR T cells, which is something everybody's been very worried about. You know, could you have issues with cytokine release? And it was very, very tolerable. This is currently in manuscript form, and we're just awaiting some final data analyses in terms of clinical correlates. I won't disappoint everybody by saying this was perfect, because there were several cases of grade 3 cytokine release for which Remedusib had to be used to literally abort the CAR T cells. So these are very active cells. The greatest activity level was seen at 0.25 times 10 to the 6 per kilo, which is a very low dose compared with 2 times 10 to the 6 per kilo. So very promising, and I guess the next step is really, where do we go with it? So thank you, Neil, for allowing me to discuss these.
Yeah, well, it's also a little bit of a palate cleaner of our brains before we get back to PARP, sort of get off into something else. Karim, actually, my brain is still fried from last night. We did a webinar on melanoma. They were talking about TILs. They were talking, I don't know if you know, Moderna has an RNA vaccine that they combined with Pembro that looks very promising. So all kinds of cool stuff going on. And, you know, again, antibody drug conjugates all over the place. Karim, any of these things you want to comment on?
Yeah, no, it's really great, number one, to see this happening eventually in oncology as a whole, but also for prostate cancer. You know, I mean, this is the number one cancer in men, and we still don't have an ADC, for example, for use. But this specific experience has been, you know, black and white because of a CRS. So, but it remains super promising. I think we have potentially good targets, PSMA, as Susan just mentioned, but also others, including maybe Kallikrein-2, maybe others. We just need to do the trials and make sure if one of those drugs work, we have them as soon as possible on the market. But you're right, it's quite exciting.
Neeraj, any thoughts? Our next webinar next Tuesday is going to be in bispecifics and myeloma. We're going to spend a whole hour on just bispecifics. Any thoughts about some of these strategies and whether you see them coming into prostate cancer?
So Neil, I think I will not repeat anything my dear and esteemed colleagues have already said. I think this is very exciting time for us and for our patients.
All right, well, let's finish out with some cases. And Emmanuel, I really like this first case, this 58-year-old African-American man. Can you talk a little bit, because I think he's right on target in terms of what we've been talking about today. Can you talk a little bit about this patient?
So this was a man that I met in my medical oncology clinic when I was at Johns Hopkins. He was African-American. He was diagnosed himself at age 58. When I took a family history, he mentioned that he had several family members, a mother, a sister, and a maternal grandmother who had developed breast cancer in their 30s and unfortunately died of breast cancer in their 30s as well. So keep that in mind for the next part. He was diagnosed with Gleason 8 localized disease, underwent a radical prostatectomy, had a positive margin, and therefore received adjuvant radiotherapy, but unfortunately subsequently presented with metachronous lung metastases. So a very unusual first site of presentation with lung mets in the absence of bone mets. At that time, that was the docetaxel ADT era after the CHARTED trial. So I gave him the CHARTED regimen, the ADT plus 6 cycles of docetaxel. But about a year and a half later, he progressed again, and again, only with growing lung mets and no bone mets. So this is a lung predominant metastatic disease. At that point in time, of course, PARP inhibitors were beginning to enter into the horizon. We could have recommended Abi or Enza because he had not received either one. We could have gone right to a second chemotherapy like cabazitaxel, or we could pay attention to that very significant family history, which is shown here. So the patient is shown in the orange arrow, and then the 3 purple deceased female relatives are all the breast cancer patients that were never tested, but presumably all had a germline alteration. Of course, this was in the early days of germline genetic testing, and I did recommend it for him, and this is a de-identified report, doesn't have any identifiable information on it, and as you can see, he has a pathogenic germline BRCA2 mutation. At that time, my colleague, Dr. Maha Hussein, who has been on your show as well, Neil, she was running a study that was called the BRCA trial. And the BRCA trial was a very small 3-armed study with 20 patients per arm. And this was for metastatic CRPC patients, BRCA1 or BRCA2 mutations or ATM mutations. And here there were 3 arms, unlike the other studies that we talked about today. There were 2 control arms, one where they got abiraterone alone, the second one where they got olaparib alone, and the third one, and this was, by the way, the first trial testing the combination, Abi plus olaparib. As you can see, only 20 patients per arm, so tiny, tiny study. My patient was randomized to the combination of both. And let me show you what happened to his PSA response. So those dates on the horizontal axis are the real dates. He enrolled around December of 2018, and within about 12 months had a complete undetectable PSA response. But more importantly, had a complete resolution of his pulmonary metastases. So he was rendered NED, no evidence of disease, no evidence of PSA, complete response. This patient had a complete response lasting 4 years, and then after 4 years of time, developed progressive disease. So quite a remarkable patient. The BRCA study has not been published yet. It has been presented by Dr. Hussein at ASCO 2022, and the publication is forthcoming. These were his side effects. He developed an interesting one that I had not seen before, which was a dry cough. Karim mentioned the pneumonitis risk. The dry cough is thought to be due to a chemical drug-induced pneumonitis, not an immune pneumonitis, but a chemical pneumonitis. This is usually self-limiting. And what we did for this patient was we reduced the dose from 300 milligrams twice a day down to 250 twice a day. And the cough subsided, although it did not disappear completely. He also developed about a 10% loss in his body weight due to just appetite suppression. He was one of those men with a big appetite. His appetite was suppressed. And over the course of the 4 years, he lost about 10% of his body weight because he was just not in the mood to eat the type of food that he liked in the past. He also had some side effects from the abiraterone, hot flashes, and peripheral edema.
So really interesting case. Karim, any comments? Have you seen weight loss in this situation? Have you seen weight loss with PARP inhibitors? I'm not sure I've heard about that.
We do see, loss of appetite in about a third of the patients who are treated with PARP inhibitors. So that's not infrequent. And when you don't have appetite, you may lose your weight. So that clearly happens.
Actually, I was just flashing on. I remember, again, this came up in an ovarian program. I think it was Rob Coleman brought up the issue of insomnia. You ever see that, Susan, with PARP inhibitors?
I have not.
They were speculating whether it might be somehow contributing to the fatigue. So, Neeraj, this patient's progressing. Any comments? You're hearing more and more about so-called BRCA reversion mutations. What are those? Can you actually pick them up on the conventional mutation? Any mutation testing, and any therapeutic implication about if you see it, what do you do?
Neil, if I may just comment on the weight loss part, the loss of appetite, real quick. I have a feeling that this, of course, it needs a larger database, larger set of observation. But I have a feeling that this loss of appetite may be a pre-nausea phase in many of these patients. They have not developed frank nausea, but they have this loss of appetite. So I have used anti-nausea medicines in these patients without frank nausea, and many of these patients have gotten their appetite, if not fully back, to some extent back. So just wanted to, I'm sure our very experienced colleagues all have very similar experiences, but it may not be very well, this fact may not be very well acquainted among our oncology and urology colleagues who are focusing on prostate cancer. So I want to make sure that I get this out so that we can have a more larger database of experience of using anti-nausea medicine in these patients who have loss of appetite. Now, coming to the question of the BRCA reversion mutations, I personally think Emmanuel is the best person to answer this, having worked with him on so many different projects. But I'll tell you give you my 2 cents. Many commercially available testing, ctDNA testing platform do pick them up. I have seen them by Godwin testing. And I do not know to what extent they are really present and to what extent they are being detected. I just have no idea. Second is, we know that BRCA reversion mutations can be of different types. Again, what is the implication of BRCA reversion mutation on the use of subsequent therapies? I don't think we have the data. I know for sure that when a PARP inhibitor is failing my patient, I do not use another PARP inhibitor. So BRCA reversion mutation testing or presence of BRCA reversion mutation is not very relevant to the decision making as far as PARP inhibitor use is concerned, because these patients have already progressed on a PARP inhibitor.
Emmanuel, anything you want to add to that? And also, Emmanuel, I kind of remember you telling me something in the past about lung mets specifically, but I can't remember what you talked about in terms of responsiveness, I think it was. Any comments?
Well, the reversion mutation issue is kind of academic, and I agree with Neeraj. Unless you are considering a platinum therapy next, that's the only context where the absence of a reversion mutation may steer you towards a platinum post-PARP if you have no other options. The lung met story is fascinating because, like the patient that I presented, there have been a few case series, including from my institution, showing that patients with pulmonary-only metastases have a super good prognosis rather than a bad prognosis. There was also a meta-analysis done by a biostatistician, Dr. Susan Allaby. She's at Duke, and she showed the same thing, that the so-called visceral metastases, we think of visceral as being liver or lung, but in fact, lung behave very, very, very well prognostically, and liver behave very, very poorly. So we should not be lumping liver and lung together. If it's lung only, those patients often do extremely well.
So, Neeraj, let's go to a couple of your cases. You have a 60-year-old man. Can you talk a little bit about him and what happened?
So this is a 60-year-old man presented with high PSA. Examination was unremarkable. Prostate biopsy showed a Gleason score 4+4 prostatic adenocarcinoma. PSA was 81.7 nanogram per mil. Scan showed widespread bone metastasis, and CT scan showed nodal metastasis. The comprehensive genomic profiling done in 2017 showed somatic alterations in PTEN and RB1. No pathogenic germline mutations were detected. However, there was a variant of unknown significance in the BRCA2 gene. So we started, at that time, we started him on continuous ADT. The patient was actually started on continuous ADT before we saw him. And when he presented with the metastatic CRPC, we had the opportunity to see the patient in May 2019. So patient responded, actually, to my surprise, despite presence of these so many tumor suppressor gene mutations, to single agent ADT through their local physician for almost 2 years. And then we started him on, enrolled him on the TALA-PRO2 clinical trial with enzalutamide plus minus talazoparib. And patient has responded, to the combination we do not know, we have not unblinded the patient, so we do not know patient was on placebo or talazoparib, but certainly patient was on enzalutamide. And he was on this treatment for close to 3 years. And again, after that, he had disease progression, and we started him on chemotherapy with docetaxel, and patient is tolerating chemotherapy with docetaxel, is still going strong. It has been 6 months, and we had took a break after 4 cycles per patient's wishes, but we resumed the docetaxel chemotherapy again. So this is the overall presentation of the case. We can see here in the CT scan, widespread lymphadenopathy, bone scan showed bone metastasis. So the message I got from this study was that they, at least with the big caveat that we do not know whether patient has been randomized to talazoparib or placebo, to me, based on this one anecdotal case who had tumor suppressor gene mutations, BRCA2, VUS, and a pretty aggressive disease, he benefited with the combination for 3 years. And bigger thing is he continues to tolerate chemotherapy with docetaxel well. So I think you decided to use this case among all my cases to tell the audience that chemotherapy is a strategy even after failure of PARP inhibitors. If this patient got PARP inhibitors, they remain candidate for docetaxel chemotherapy and can tolerate chemotherapy well.
So, Emmanuel, any thoughts about this case? You know, I guess, yeah, we don't know. I mean, I guess it could have just been enzalutamide alone, but I mean, I think, it was like 600 patients in TelePro 2 who are HR, not, HR proficient and a hazard rate of 0.66. I guess it could have been enzalutamide. Any thoughts about this case? I kind of wonder, I wonder if we didn't have the BRCA data, if you were only looking at the non-BRCA, whether you would also be kind of hesitant to move forward. Any thoughts, Emmanuel?
This patient's bone disease burden is not very extensive. Looking at this bone scan, he may have 3, 4, 5 spots. He doesn't have 100. He also had a very favorable response to ADT alone, as prescribed by the original oncologist. And in general, patients that have a prolonged response to ADT alone may also have a very favorable response to enzalutamide alone. So we're never going to know, at least we don't know at the moment, whether he did or did not get the talazoparib. But this patient has a good prognosis, even though his molecular status would have predicted a bad prognosis.
Interesting. So, Neeraj, I also pulled this patient too, because I think it was kind of a cool story in terms of managing toxicity. If I remember this case correctly, with a patient on a PARP inhibitor. Can you talk about this patient who actually ended up getting olaparib?
So this patient presented with systemic symptoms, very high PSA in 2012. PSA was 651 nanogram per ml. Prostate biopsy showed poorly differentiated prostatic adenocarcinoma. We could not get the original report for this patient. And patient was, the bone scan showed extensive metastatic disease. The comprehensive genomic profiling showed a somatic alteration in BRCA2 gene. Tumor P53 mutation was present. Patient had bilateral orchiectomy, followed by radiation therapy to the brain and spine lesion. He was started on bicalutamide therapy by his local physician, in addition to leuprolide. And interestingly, patient had response to single agent ADT for about 5 years, despite having, these are real world cases, which I just brought up from our clinic. And then he was diagnosed with mCRPC in October 2018 with nodal metastasis, rising PSA, only responded for 13 months to enzalutamide. So unlike the previous case, which you could have predicted longer response to enzalutamide because he had such a long response to single agent ADT, he responded for a relatively short time. Consistent with what we saw in TALA-PRO 2 trial, the radiographic PFS was only 13 months. And then we started him on olaparib in 2019, December, is still responding to olaparib. And this was through the BRCA-WAY trial. We all are doing this trial together, led by Maha and Emmanuel. So it's still responding very well. So single agent olaparib. So this is again a very intriguing presentation. Single agent ADT worked for 5 years. Enzalutamide works for 12 months or 13 months. And then a fantastic response to olaparib.
I want to see what Emmanuel has to say, but first, I remember, I think this patient had a problem with anemia that you had to deal with. Any comments on that?
But we can discuss about anemia. I mean, this patient did develop anemia. I can tell you that on olaparib. And we had to decrease the dose of olaparib by 1 dose reduction. So grade 3 anemia happened immediately, almost immediately after starting olaparib. It was 8 gram% of hemoglobin down from 13 gram%. And initially I thought patient will have to discontinue olaparib. But surprisingly, just by 1 dose reduction of olaparib, patient is tolerating olaparib for 3 years now. So I think what I learned from this patient was that dosing is very important in PARP inhibitor. And with dose reduction in a timely fashion, most patients are able to tolerate PARP inhibitor or combinations extremely well for many years.
Emmanuel, any thoughts?
Yeah, I want to go back to a comment that Karim made and to emphasize it again here. This patient has a BRCA2 loss, meaning a homozygous deletion of both copies of the gene. And those patients anecdotally respond very, very well and very, very long. This was first reported by Johan de Bono and then confirmed by other groups. And if you ever see the word loss on an NGS report, it's not the same as mutation. It's actually a better prognostic factor in the context of PARP inhibitors.
That's a really great
point.
point.
Yeah.
So it's amazing how often I hear stuff I've never heard before. And I've never heard that. I've seen the deletion, but that was really helpful. All right, let's go hear about your 67-year-old man, Karim. Gets who started out in 2019. What happened with him?
Right, sure. So at this time, he was 64-year-old, and he presented with urinary symptoms. PSA was high, about 19. Biopsy were performed. Bad news, glycine 10, and the bone scan / CT scan showed bone disease and lymph node disease. He was treated at this time with ADT alone in a community center. This was really the time that people were arguing as to whether ADT should be intensified, mostly with the Taxol at this time. This was kind of prior the eve of the second generation of hormonal agents. Anyway, 2 years after that, he developed castration-resistant disease. He received abiraterone, which actually didn't work very long. As you can see, in January 22, he presented again with hematuria, PSA progression, and actually the local symptoms required a TUR. So at this time, he was referred to us, and we looked at, we did a molecular analysis sequencing, and we could detect a germline BRCA2 mutation. He actually had a history, I forgot to say, he had a history of, I can't remember, I think breast cancer. You can see the imaging parameters, the bone scan to the left-hand side and the CT scan to the right-hand side, with evidence of both bone metastasis and the local progression. So we started on a combination. I was asked to speak about combination. So this gentleman actually had rucaparib and a PD-1 inhibitor atezolizumab in a context of a phase 2 trial. Actually, this worked quite nicely for him. He became asymptomatic. Remember, please, he had hematuria. And you can see the PSA response, or PSA drops, quite dramatic. But actually, he also developed some toxicity with neutropenia, which also happens sometimes. And in his case, it was quite mild, grade 4, which actually required a treatment holiday last winter. And you can see that. And during this drug holiday, the PSA rose again, as you can see. So we had to play with different dose reductions here and there. We started him again on drug in spring, and as you can see, his PSA is declining again. Again, I saw him Monday. He was asymptomatic, clinically very well tolerating the drug. but still some hematological issues. So we had to give him some holidays and reductions. But clinically, he's doing extremely well. Again, this phase 2 trial has one big weakness. It's a non-comparative trial. So it's going to be hard to figure out from this trial whether atezo is helping anyhow recovery, or whether what we're seeing here is simply the effect of recovery. But at least for that gentleman, it appears to be a good choice. And this is it. You asked me to do 2 slides. It's 2 slides.
Good job. So, yeah, really fascinating, though, how the PSA went up when the dose was held. Emmanuel, have you seen that? I mean, I don't know. I guess it's probably just the PARP inhibitor, as you were saying, but that, just by holding the drug, you see the PSA go up, and then you bring the drug back, and it goes back down?
Yeah, I've seen it when I've had to stop olaparib because of cough or pneumonitis, and then I started a lower dose. It always happens like this. Yeah.
Wow. That is so interesting. Susan, I know you've written about the issue of IOs. It kind of looks, from what I can tell, pretty disappointing. I don't know whether this really is a case of rucaparib. Any thoughts about the future of IOs in prostate cancer outside of MSI high, Susan?
I'll tell you, in all honesty, I sort of despair. And in spite of the fact we have probably 3 or 4 clinical trials, I mean, Merck has had several clinical trials where they've been negative, essentially with a variety of different IOs. And at the end of the day, one actually asks the question, should we even be looking at IOs anymore, despite the negative trials? So I would say that it is not without risk that we use these drugs, although, again, in microsatellite high, in other cases, it's very, very reasonable. But again, I'm not so sure that we're doing ourselves a favor by designing large multi-center trials with drugs that persistently don't seem to have any significant impact on the disease. So to that end, if I could make mention of this one, which does involve an IO, although at the last possible moment. So this is a patient I inherited from a radiation oncology colleague. This patient had initially presented at age 65 with recurrent UTIs. His PSAs were vacillating and finally went up to 23. The gland was markedly enlarged, and biopsy showed multiple cores of Gleason 4 plus 3, 3 plus 4, and 4 plus 4, 8 out of 12 cores, anywhere from 20 to 90% of core involvement. He was staged as a clinical T3B disease and going into the seminal vesicles, and was advised androgen deprivation therapy with, now remember, this is 2010, this is a while ago, with high-dose brachytherapy, which was iridium 192 seed implants, and along with with external beam radiation, both to the prostate and to the pelvic nodes. So the treatment was completed in 2010. He had some mild hematuria, and then in 2011, PSA 0.34, 0.42, 0.59. Now, the patient had a lot of problems being on hormonal therapy at that point. He had come off after the radiation. There was no recommendation at that time of 18 to 24 months, given when this occurred. Nevertheless, had profound fatigue and barely could get his testosterone up to non-castrate levels. Roughly around the same time that he was completing radiation, he reported a subareolar mass in the left nipple, and that's around a few years later. He's being monitored very closely during that time. Mammograms showed a marginated mass with some nipple retention. And also here, we found out that there was a niece who was BRCA positive and underwent a mastectomy. So all of this sort of came in the retrospectoscope. And this is just to show you, if you can see the cursor in the left field, the sort of nipple inversion. And the very far right, of course, is when they're starting to do the actual lesion localization. So he underwent a sonogram guided biopsy of the breast lesion. It came back as invasive ductal, and to move forward, he was ER, PR positive, HER2 negative. He had a mastectomy followed by docetaxel, but no radiation to the left breast, and was on an aromatase inhibitor and ultimately went on to tamoxifen. During that entire period, PSA started to rise. He was off a GnRH agonist at that time. We put him back on, and he really could not tolerate the fatigue. And every time we discontinued it, he never quite got back to non-castrate level and remained hypogonadal. So over time, and with continued rises in the PSA, we were doing MRIs. And in the past, his doctor had noted that with the increase in PSA, there was a suspicious area within the treated right seminal vesicle. He put an isolated seed in there, which seemed to have some impact on the PSA, but kept the seminal vesicle absolutely stable. However, this continued to get bigger, as we can say, and at that point, came to see me. And what you can appreciate is on the far left panel, you can see the rectum, the bladder, and the seminal vesicle, and then subsequently you can see a seed. So I don't know if you can see the cursor here, but it's right over here where there's an isolated seed in there. So the patient did well for a short period of time and then started having a rise in his creatinine. He called to tell me that he was going for just a routine stress test at another institution, given his history of a quadruple bypass and significant coronary artery disease. Someone recommended that he undergo an echo, and both an echo and a cardiac MRI showed a right atrial lesion. Now, first thing that anybody, I believe, would imagine is probably breast cancer. It could be metastatic melanoma, colon, lung cancer, but hardly would you expect it to be prostate cancer. So there's a PSMA scan that you can see there with this sessile lesion that's pushed right up against the right atrial wall. It was not impeding outflow. You can see it there on the PSMA, and you can see it right over here. So this was biopsy proven to be positive. And when we noticed that his creatinine was rising despite being on ADT, you see there's a right hydroureter nephrosis. You can see he was developing obstructive uropathy as a result of a thickened bladder wall on the right. And again, this enlarging seminal vesicle mass. So no response to ADT. And this is roughly about a little over 1 year ago, when all this data first came out, and there was the results of the PROpel trial, and I would have put down quite a bit of support to say that this was going to be the treatment of choice. The lesion in the atrium was 3 centimeters. PSA was rising. Creatinine, as you can see, was 1.7 to 1.8, due actually to the blockage from that seminal vesicle that was enlarging. Now, I'm going to bypass the role of MSI testing because there are different platforms that can be used. I was very concerned because the urologist could not help this gentleman whose right kidney was getting bigger and bigger. And so I went back over the chart, and again, the patient had been transferred to me by both the breast oncologist and the radiation oncologist, and he had not undergone somatic profiling. And so we went back and asked that the left total mastectomy specimen, which is BRCA2 positive, to please be evaluated. And you can see the tumor mutational burden. And it came back as microsatellite instability indeterminate. The right atrial mass had 64 mutations, also microsatellite indeterminate. There were alterations you can see in ALK, AR, ATM, TP53. And we sat down and had a very direct talk about what should we do. And so we started out initially with that olaparib and abiraterone with absolutely no impact on renal function, atrial mass, or the seminal vesicle. These were the options that we all discussed. And when we asked pathology to please go back and to reanalyze the data, we found that he was microsatellite high. He had 4 cycles of pembrolizumab. the right atrial lesion, at least with the first iteration of the cardiac MRI and PSMA scan, was minimal. Seminal vesicle was minimal, no hydro. And then, of course, the question was, how do you maintain? This was just done the other day. This is the PSMA PET scan from just about a year ago. You can see the lesion here. There's actually hydroureteral nephrosis. There's a lesion in the bed, completely gone. So it begs the question that I think we all are doing, is that let's everybody do germline, but I think that sometimes we are negligent in getting the whole package, which would include the somatic mutations as well. So I never would have dreamt that this was the issue, but it was just, as far as I'm concerning, his PSA is now less than 0.05. The hydronephrosis is gone. He's voiding. His creatinine has gone from 1.8 down to 0.9. And we don't see any disease either in the atrium or the seminal vesicle, and PSA is less than 0.05. So it took over a year for us to figure this out, but I'm glad we did. And I'm glad I had the option, at least in this particular case, where Pembro was helpful. Now, whether or not 4 cycles is enough, he's actually refused to do more than 4 cycles, largely because he has fatigue. And he is such a, I think, a medically delicate individual that I was worried about, of course, side effects that could be associated with it, but doing very, very, very well. So open for discussion. It is a wow.
Wow. Yeah, just wow. What a great reminder in terms of not ever forgetting about MSI high. We're pretty much come to the end of our program here. But Emmanuel, any comments about this case and the teaching points from it?
It's crazy. This case is crazy, but it does teach you 2 things. One is, if you have a germline BRCA mutation, it doesn't mean you can't also have microsatellite instability. You can have both. You can be hit by lightning twice, I suppose, in some cases. And the second lesson is, it's virtually impossible in prostate cancer to have a TMB above 50 without having microsatellite instability. It just doesn't happen. So when Susan presented that, even irrespective of what the microsatellite was called, especially in the context of an MSH6 mutation, which was also listed, there has to be, microsatellite instability until proven otherwise. But I've never seen a patient like this, Susan, and I would have recommended Pembro, and I'm glad that that's what you selected.
I'm not sure I've seen a CR in the atrium before. Final comment from Karim.
Yes, I mean, very similar to what Emmanuel said, but I just want to emphasize that I've heard and I've seen a few cases of men with both BRCA2 alterations and MSI high. And in all, of course, hard to make it a series, but in all cases, actually the IO worked, and not necessarily the PARP inhibitor. So I think this is very important to tell the audience. These patients are rare, but if people see those alterations, probably they should give a preference to the IO if they can.
All right, just one final question. I'm going to come back to Emmanuel. What about just TMB high? To start with, there's a pan-tumor approval for over 10. Will you try an IO or pembrolizumab in that situation? What about 20? What about 30? And also, what about if the TMB is coming from the plasma, from a liquid biopsy? Do you look at it differently?
Yeah, most of the TMB biomarkers have been credentialed from tissue, not from circulating tumor DNA, so we should not really be using those as a definitive call. Our esteemed colleague Neeraj has published, I think, the one and only paper looking at the TMB high patients with prostate cancer that both included the microsatellite stable and unstable subsets. And it's relatively rare to have a TMB above 20, maybe 3 to 4%. And most of those, although not all of those, are going to be MSI high. If you have the occasional patient who has TMB above 10 or between 10 and 20, in the absence of microsatellite instability, Neeraj's paper suggests, it was a retrospective real-world analysis conducted with Foundation Medicine data set, that the Pembro works better than chemotherapy in that context, given all the caveats of retrospective analyses. But I would only do that if other options, other life-prolonging options have been exhausted.
So I think it's really a sign. We at ASCO, one of the docs said, part of the things we were talking about said, back in the day in prostate cancer in 2019, that's the way they started the comment. And I'm like, yeah, back in the 2019 was back in the day. Anyhow, thank you so much, Neeraj, Emmanuel, Karim, and Susan. It's been so great to spend this time with you. After several hours, there's still so many things we didn't get into, so there's a lot to talk about nowadays in prostate cancer. Thanks to the audience for tuning in. Have a great day.